Hello? Hello? అంతకుముందు ఏదో స్పీకర్ తీసేసావు కదా నువ్వు.
Ma'am, can you hear me?
Morning, Amma. Yeah, I can hear you. Good morning
Okay.
and all the best.
Good morning, ma'am.
Yeah. Yes.
Yes, ma'am. I can hear you.
Ma'am,
Thank
yes,
you.
ma'am.
Thank you, ma'am.
Hello, ma'am. Very அம்மா ஸ்மிதா ஆடியோவே வரலையேம்மா எனக்கு. யூ மியூட்டடா எல்லாத்தையும்? இல்லையே, அன்மியூட்டடா இருக்கு. பட் ஐ குடன்ட் ஹியர் வாட் யூ ஆர் டாக்கிங். లైక్ ఓకే ఓకే అరుణ అక్కడ నాకు హియర్ చేయడం ముడియదు. స్మిత ఇస్ టెల్లింగ్ దట్ యూ విల్ సీ దట్. అరుణ లైట్ చాలు పారి. లైటింగ్ వద్దని చెప్పలేదు. ఐ ఆస్క్డ్ లక్ష్మణ్ ఇప్పుడు నాకు వినపడదు. I could not hear anything what she is talking.
Ma'am, I have muted. Yeah, when we'll start, we'll.
ఇప్పుడు she started. Because my co-host kada, I can talk and whenever I want, but I am not able to listening. Usha, please listen avvaledra naku. Unmute ni chesida undi.
Now she is speaking.
Unmute. ரெண்டு டார்க்கா வந்து அక్కడ அங்க வந்துட்டுமா நானு. அப்ப ஒரு
இந்த சிக்னலும் வராது.
சொல்லிட்டு நேற்று வச்சு no, what I'm telling, what she's see
பேசினாக்கா அதுதான் மேம் பண்ணிட்டே இருக்கோம்.
அங்க மியூட்ல தான் இருக்கு. ஆனா அங்க
Hello, good morning, Amma. Are you able to hear me?
Yes, ma'am. Your voice is audible, ma'am.
Okay,
Yes,
okay.
We can hear you, ma'am.
All
We
the
can
best.
hear you.
Okay, ma'am. Thank you. Sorry.
Good morning, ma'am. Yes, ma'am, we can hear you. Morning. Good morning.
Mute, unmute.
Ma'am, shall we start?
Smita, madam told
Yes,
us
ma'am.
to start this. Ma'am.
Okay. Respected learned delegates from across the country, continent and academia, a very warm good morning to one and all. I'm Professor Smita, Department of Mental Health Nursing, feeling privileged to welcome you all on behalf of Narayana College of Nursing, Nellore, for the 4th International Conference webinar series on clinical sequelae of COVID-19 survival. Whom to talk? Yes. Yes, ma'am. We have already started.
Poster. What? Good morning. Are you hearing me?
Yes, ma'am.
Yes, ma'am.
We are able to hear.
Yeah,
Good morning,
Madam Indira, Madam.
Good morning,
morning,
Madam. Welcome to our conference.
Yeah. Good luck to ourselves and our learning nursing fraternity and everyone.
I welcome both the Vasanta Kumari Madam, Jayanti, Principal Narayana College of Nursing, and
Good morning, ma'am.
Dr. Rajeshwari,
Morning, ma'am.
Good morning,
Vice
ma'am.
Principal Narayana College of Nursing, and Serif. You can switch on your video also so that we will be able to see you. Welcome to this session, first morning session. Thing is, we
Yes, ma'am.
inform you that Dr. Datuk Madam from Malaysia has some other problems, so she is not joining. She has deputed some other person, so it will be going on. So, can we start with Valli Madam's presentation, Smita?
Yes, Madam, we told that we will wish and we take the Almighty's prayer song.
Yes, ma'am.
Yeah.
There?
Yes, ma'am. Prayer song is there, ma'am.
Yeah, we'll start with that.
Yes, ma'am. Smita, please start with the prayer song, no?
Yes, ma'am. Now let us pray to God Almighty to shower His blessings with a prayer song. Yes, ma'am, a prayer song is there before that. Now, show that. Yes, ma'am. Yes, ma'am. Prayer song.
Smita, we could not hear the song.
Yes, ma'am. Yes, ma'am. We are playing.
राजं भजे श्रीविघ्नराजं भजे श्रीविघ्नराजं भजे श्रीविघ्नराजं भजे श्रीविघ्नराजं भजे श्रीविघ्नराजं भजे हम भजे तमिह श्रीविघ्नराजं भजे राजं भजे सन्ततमहम् श्रीविघ्नराजं भजे सन्ततमहं श्रीविघ्नराजं भजे कुञ्जरमुखं श्रीविघ्नराजं भजे तमिह श्रीविघ्नराजं भजे सन्ततमहं कुञ्जरमुनिविघ्नराजं भजेऽहमिह श्रीविघ्नराजं भजे सन्ततमहं दन्तिकुञ्जरमुखम् अन्तकसन्ततमिह श्रीविघ्नराजं भजे सेवित सुरेन्द्रमहनीय गुणशीलं जपतपसमाधिसुखवरदानुकूलं सेवित सुरेन्द्रमहनीय गुणशीलं जपतपसमाधिसुखवरदानुकूलं पावित सुरमुनिगणभक्तपरिपालं भयङ्कर विशन्तमातङ्गकुलकालं भावित सुरमुनिगणभक्तपरिपालं भयङ्कर विशन्तमातङ्गकुलकालं श्रीविघ्नराजं भजे श्रीविघ्नराजं भजेऽहं 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 भजेऽहमिह श्रीविघ्नराजं भजे सुरेन्द्र
Smita, can we have the
Yes,
welcome
ma'am.
song? Can we have the welcome song?
Yes, ma'am.
Can we have the welcome song?
Now, let us listen to our institutional welcome song on this occasion. Yes, ma'am. Well, yeah, we have a welcome song. Yes, ma'am. Welcome song is there. We are playing.
We welcome you here. We welcome you
Yes, ma'am.
here to the world of in and I,
Yes,
to the
ma'am.
world of in and I. The brighter the lighter, the brightest together. Knowledge and wisdom, oh, service forever. Will make your desire, will make us so higher. We welcome you here. We welcome you here to the world of in and I, to the world of in and I, to the world of Narayana, to the world of in and I.
Smita, carry on with the next program. Smita.
Now, let me invite Professor Leta ma'am, HOD, Department of Medical Surgical Nursing, Narayana College of Nursing, to deliver the welcome address. Over to Leta ma'am.
Morning to everyone. It's my pleasure to welcome all the eminent speakers, guests from different countries for the both international virtual conference to share your knowledge and vast experience with us. First and foremost, I welcome our founder, chairman, Dr. Narayana and Dr. Puneet, president, and Dr. Sindhura, joint secretary, to given this best platform to organize this conference. Next, a good leader has the confidence to stand alone, the courage to make tough decisions, and compassion to listen to the needs of others. Ma'am, can you hear me, ma'am? Can you hear me, ma'am?
Yes, ma'am, we are able to hear you, ma'am. Please continue, ma'am.
Okay.
Please continue.
Okay. So a good leader has the confidence to stand alone, the courage to make the tough decision, and compassion to listen to the needs of others. I cordially welcome our Honorable Madam Dr. S. Indira, Principal, Narayana College of Nursing, organizing chairperson of this conference. Next, orchestration is the capacity to transform vision into reality, to lead people and work beside them. It's my privilege to invite Dr. Valli, Deputy Director of Nursing, to this conference. The mentor encourage you to live with love, courage, and adventures. Give us a tomorrow more than you deserve. My gracious welcome, Dr. Ramesh Prasad Mahatam Rai, Lecturer of Applied Science, Lincoln University, Malaysia. The art of teaching is the art of assisting discovery. With immense pleasure, I welcome Dr. S. Vasanta Kumari, Associate Professor, Institute of Health Science, Wollega University, Ethiopia. The teacher affects eternity. She can never tell where her influence stopped. I deem it a great pleasure to welcome Professor Jayanti Ma'am, Principal Srinarayana Nursing College, for her valuable presence. The teacher can change lives with just the right mix of chalk and challenge. I heartily welcome Dr. Mariam Carroll, Director, School of Nursing Science, University, Nairobi. The mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, the great teacher inspires. I cheerfully welcome Dr. Duke, Senior Lecturer, Lincoln University, Malaysia. The best teacher lodges an intent not in the mind but in the heart. I heartily welcome Dr. Rajeshwari H., Vice Principal, Narayana College of Nursing, to join us for this conference. By doing what you love, you inspire and awaken the heart of others. It's a great privilege to welcome Dr. Gopi Chandran, Associate Professor, College of Nursing, AIMS, New Delhi, and TNA President of New Delhi branch. Teaching is the greatest act of optimism. So I would like to welcome Mrs. Jayanti, Professor, Narayana College of Nursing. Good teachers are the one who can challenge your minds without losing their own. So with immense pleasure, I welcome Mrs. Kanta, Associate Professor, Narayana College of Nursing. To the world, you may be just a teacher, but your students, you are a hero. So I heartily welcome Mr. Sharif Muhammad to be a part of this conference. A good teacher can aspirate hope and ignite the imagination and instill a love of learning. It's my privilege to invite Mrs. Smita, Professor, Narayana College of Nursing and Conference Coordinator. And also I am welcoming all the participants who are participated in this conference. So once again, I am welcoming all for this conference.
Thank you very much, ma'am, for your wonderful welcome address. This sets a perfect platform for our speakers to deliver their presentations. Thank you once again, ma'am. Now, I request Associate Professor T. Usha Kiran, Department of Obstetrical and Gynecological Nursing, to continue with the rest part of the session.
Chairman, participants, may I now request Usha Kiran, can you be a little more louder? No, we could not hear.
Good morning to one and all. Is that okay, ma'am?
Yes, yes.
One and all. To our learned participants, may I now request the distinguished speaker of the day, Dr. Valli ma'am, Principal, Government College of Nursing, Kannur, a consistent and successful educator and administrator at UG and PG levels, with extensive background of developing workshops, mentorship programs, with 31 years of experience, 5 awards, and 7 publications and presentations. She is having an extensive experience as examiner and paper setter for UG and PG examinations at different states and universities. It's my great pleasure to invite you, Dr. Valli ma'am, for unveiling the theme. Over to you, Dr. Valli ma'am.
Good morning to all. I think a little bit voice, we need to get it from the host because there is a problem that we are able to, I think the participants may be hearing. Very nice that we started with the Almighty's blessings and we are going through it. So 2 days, 4th international conference and first webinar was been organized by the Narayana group of colleges and Narayana Nursing College, Nellore. And we congratulate you for this. And I wish you best wishes for this 2 days program to go ahead with a learning platform for all the learners who are been logging this and later on also going to have this login. First of all, I express my thanks to Indira Madam for making me a member in this panelist and a learning person. And I would like to learn because from the birth to till our life, we are going to learn and learn. Whatever we learn is also very less. Still, we need to learn. And especially in this pandemic, I think that I would like to welcome you for all of you for my session that are you able to see?
Yes, ma'am, we are able to see you.
It's a warm, pleasant welcome. A mixed seasons are been going on. And in this pandemic, a suitable theme was being taken, what to be done. And whatever we heard from the public or from the professionals or everyone, it is the name of the pandemic disease, the corona that was been hearing. When you say hello, first of all, we'll say, are you safe? What happened to that? That means everybody is very eager to protect themselves and also to protect the community. On this context, the seminar, the international conference is been very suitably taken up on the eve of this pandemic and on this to make the people to survive from the birth, from the womb to tomb. It's a very, very suitable thing that everyone, not that we need to take only vulnerable group or this group or like that. It is not like that. We are going to see that we are going to take up everybody's health and one need to protect themselves. Once this pandemic, we are going to hear, it is the pandemic 2019 December was started, first wave, second wave, and the third wave. And now we are been hearing there is a Delta variant and all other things. The evolution process is going on, changes are been going on. One need to be prepared for everything. So it's my privilege to unveil the theme of this conference, of 4th International Conference and first webinar organized by the Narayana College of Nursing, Nellore, under the leadership of the Dr. Indira Madam. So I welcome you all to have the unveiling of the theme. It's my privilege to unveil the theme of today's 2 days conference is clinical sequelae of COVID-19, survival womb to tomb. When we say that this clinical sequelae of the COVID-19 survival to womb, yes, we know very well that the COVID has taken up the upper part and it has been not causing the disease during that disease process. It is also having an impact as a process of its pathogenesis and pathophysiology entering into the human body and taking its upper hand and causing, and the individuals are being recovered from that. But even then, the clinical complications and potential problems are being experienced by the various group of the individuals. So we need to survive with all those things by having our preparedness, building up our immunity, and taking care of the pregnant mothers, the child, the infant, the fetus who has been growing until the end. When you go to the terminal care also, we don't want to leave them, we wanted to take. And everybody knows how this pandemic has taken our time and it is going on. We know that in December 2019, a novel coronavirus named as COVID-19 was been caused a series of acute typical respiratory diseases started in Wuhan, China. And this spectrum of illness is ranging from the asymptomatic infection to severe acute respiratory distress syndrome and pneumonia like, even it is very fatal and causing the death. I think today you are going to have a platform of epidemiology you are going to learn, and mostly the common symptoms that are caused by the coronavirus: extreme tiredness, unexplained fever, cough, aches and pains, sore throat, and also shortness of breath of various grading, and hypoxia that takes the life of the individuals, making the people, we have been heard that there is no beds, there is not, but our government, the community and the people, everybody has taken step to fight with this disease and to have our survival. It's a very, very, very suitable theme that we have taken, that from the womb to the tomb, all the different developmental age group people are been having their immunity levels of different categories, and it may be a host immunity, and later on it is the natural immunity that makes them to have the herd immunity, and later on the virus will take up the pathological immunity and the hypersensitivity, and it has been causing most of the sequelae and the disease severity and individual responses are being there. When you look into the role of the nurse during this COVID-19, yes, it has been there from the prevention till the rehabilitation. All the topics have been covered in this theme, and it has been going to be learned in these 2 days. I wish everybody to have a very good interactive sessions and a good learning platform, knowing especially the role of the nursing fraternity, where they were been there, the frontline warriors who have been working. We have seen they have been dedicating and they have been sacrificing their family, their personal and their life. And also, so we all salute them for their care that they were been doing it, and we learn more and more about that. When you look into it, it is now this pandemic has been taking the most of the respiratory and pulmonary sequelae you are going to learn. Most importantly, pulmonary embolism with a simple cough and the pain in the chest, and maybe a dull chest pain, and it may be with the shortness of breath with a various gradient. Sometimes you may say without anything, a person will be loss of consciousness and may not show any symptoms. Later, when you see the persons, maybe all vitals are upset and maybe certified as dead. So these are, and what to be done, the preventive step and rehabilitation things with the cardiopulmonary complications, a good diet, a balanced diet. I think that we are going to learn, and everybody has been taking care. I wish all the frontline workers take care of yourself and also see that the community will take care of themselves. And mostly we need to modify our lifestyles and habits. And you are also going to have a session where you are going to learn what is your actual health status and what is your optimum health status, what should be done to be healthy, making your heart to be healthy, coming out of some of the habits that are been there, smoking and alcohol, and eating a healthy diet, having movement of our body, doing exercise, stick on to your daily routine, and knowing your levels, what is your blood and your body has been telling, where is your cholesterol level, reduce your stress. See that there is a good session on the mental health and what are the sequelae and impact of the COVID on the individual's mental health status, and take the medications prescribed by the doctors, advised by the committee people, not by your own. Though nowadays we are seeing the home isolation and treatment at home on the telemedicine and telenursing, it has been going on. And mostly we concentrate on the rehabilitation, though it has been 21 days, 14 days, 7 days, the individuals with the way different duration of the disease period, they are been recovering. But even then, we want them to come back to the normal and to be into a normal status, like we take care of our heart. The heart is very, very precious organ. We say once you give a heart and give it to somebody, and you are going to say that you are not going to disturb anyone, and you will walk and you will work with your full heartedness. Hope our nurses are also will make our clients and the individuals into that kind of the things. And coming to the most importantly, on this end of this session, 2 days international seminar, nurse takes a very, very pleasant role, making the clients and the individuals and the family and the community to educate. Education of various levels will be going on, like learning. First, we learn from the experts. The panelist members are very experienced people that was being organized by the Narayana group of the institutions. And we thank them and we are going to learn from them. It may be a little bit time, but mostly it may be a brainstorming session for educating the clients, educating the family, and also educating all the nursing fraternity, and especially the health team members. Most of them are the participants. I wish them to have a very good luck and to have a good platform. And I thank the organizers that education is nothing but bringing a change in the individuals. So by learning and by cultivating all the habits for the past 2 years, since December 2019, we made ourselves looking into our hands, always washing our hands and scrubbing, the SMS we say, then maintaining the distance, social distance, not traveling. That is the reason we are having these webinars and the platforms, and also making ourselves to be of our sanitizing ourselves and maintaining that, and wearing a, most importantly, the mask, that once you are in any place that you see that the mask is been safely worn, and you will take care of yourselves and you will have. So have a good session. And going back to our thing, thank you very much for giving me this opportunity. And we thank one and all to have this learning session and other good platform for you to have the things. And we unveil the theme of today's as such. It is been the clinical sequelae of COVID-19, survival womb to tomb. Good luck to everyone. Thank you. Thank you one and all. And I congratulate the organizer for giving me this opportunity. Thank you, Madam Indira, Madam.
Thank you, ma'am, for your excellent unveiling the topic. What we have thought, what's the objective we had in our mind, you have told. The main objective was of this conference is to educate the nurses as well as the public. That's why we have taken up. So as we are educating our nurses in various places all over the world, it will go to the public where we can reduce the third wave, which is going to be very threatening to our community. Thank you, ma'am. You have given a very nice info.
Thank you very much, ma'am. We wish our learners to have a good platform. Thank you.
And I want to congratulate and welcome you as our DDM in nursing of Andhra Pradesh government.
Still time is there, madam. First of all, thank you for, now we congratulate our Professor Kumarama madam. Is been our regular DD, and madam will be there till her services June 30th. And God made me to have an opportunity to be coming over there on July 1st. Thank you for your wishes and your concern.
And I assure we will be with you on behalf of our private management and all private colleges and government colleges. We will be with you on the way wherever you are going to uplift our profession. We welcome you wholeheartedly, ma'am.
Thank you, madam. Thank you.
Thank you very much, ma'am.
Yeah.
Now
I stop my sharing.
Okay.
Thank you, madam.
Thank you.
Now I'm going to. Is it audible, ma'am?
Yes,
Usha,
you are audible, ma'am.
Little more louder, you speak.
Yes, ma'am. For distinguished participants, may I now request Dr. Indira S., Principal, ma'am, Narayana College of Nursing, Nellore. I feel privileged to talk about madam and about her achievements. She is an excellent administrator with superb leadership and professional productivity, eminent administrator for building programs through proven competencies in administration, with more than 35 years of experience and 14 awards, publications of 35 national and international. She organized many national and international conferences, guided many PG and PhD students. It is difficult to explain all her achievements within the limited time period. I'm honored to have you here for today's presentation to give keynote address to our esteemed participants of this webinar. Over to you, Indira ma'am.
Good morning to all of you. I want to thank Usha Kiran, who has introduced me, and I want to thank our organizing people to make such a good conference today. this idea was started once. You know that our Narayana College nursing institutions are having 12 roles. We are working both in hospital side and nursing colleges also. After this corona second wave, those who are recovered from college, hospital, we are calling back and asking how they are, any problem there or like that. We are calling. Thing is, once we are calling about 10 people, among them, at least one person is dying or one person is having stroke, whether it is a cardiac stroke or cerebrovascular stroke. That's make us to think this topic, because we are very happy that our government is very happy to say that we came out of second wave and we are successfully come out of second wave. But the post complications are very high, which we have to think a lot. As being a frontline healthcare workers, I have to tell, we will be the frontline healthcare workers. We have to think of this how we have to overcome to our clients. So this time I want to tell you only two things, that is, we, the nurses, with our wholehearted works, 99% of people are recovered from the COVID. 99%. But 1% of people has expired in this. It is all because of our nurses' effort. All of you know, doctors worked hard. We worked hard. All our other people also worked hard. But all 24 hours, 12 hours work, we, the nurses, only did in this COVID condition. Without going for natural calls, without seeing the family members. You might have seen many viral things in our YouTubes, how the nurses has suffered and how they have come out with their stress in this COVID condition, pandemic condition. But to overcome the first coming days, we should have a good knowledge how to prevent this forthcoming sequelae also. So that only we have taken this topic, and I appreciate and I congratulate all our nurses all over the world for this achievement, that we have only 1% death among this COVID. They have told 3/4 of the population, 1/4 of the population will die off, and 3/4 will be there, and that 1/4 will be going for some complications, and 1/4 will be having some irreparable complications, like we have to go for rehabilitation, like that. But God's grace and our hard work, we have reduced that one. And another one concept is vaccination. All of you know that vaccination is been given for 2,187 crores of people all over the world, even though the rate has not reduced. A small introduction worldwide, if you are taking, so totally we have more than 17 crores of people, and died is 3 crores only. A small one, this is up to June 11 we have taken up. So you see, India is in third stage, but the death rate is only 1%. Whereas the world is in world it is 10%. In India, it is only 1%. It is a big ground we have to give to our nurses. With all our training programs, with all our requests, they have done a very good work without their problems and other things. We wearing 12 hours this one also. You see that the thing, outcome of total closed case. This is recovery rate as well as death rate. You see that death rate. It is coming down nowadays, and the recovery rate is going very highly. So which means, say, our nursing care and health care is giving us a good hope, and we can overcome the third, and we can overcome the sequelae also. So the COVID-19 pandemic has already changed our collective calculus of uncertainty, because there is no reference regarding what are the crises will be happening and how it will be going on in our memory. Then the problems are, it is not at all left over any part of our body. It is affecting all the systems in our body, because a person who is having coronavirus is going for hypoxia. You know, all our vital organs, our accessory organs are need of oxygen to work, which is affecting. So here, the COVID-19 provides protection against reinfection. Is the battle of the hour, for which we are having vaccination. But with the vaccination only, we cannot come over this ones, because you know, most of our populations are not vaccinated and our children are not vaccinated, and people with coming groups are not able to have group or herd immunity for this disease, as it is going on changing its variant. And in pulmonology, you know, pneumonia, acute respiratory distress syndrome, and respiratory failure. Whereas in neurology, because of hypoxemia, it is going for headache, neuropathy, encephalopathy, and cerebrovascular diseases. In our hospital, among hypoxia people, those who are made in oxygen, we have found every 31 patient is having hypoxic syndrome. That is, they are having more type of amnesia, and they are not able to have comfortable positions and other things. And you know, now we are having black fungus diseases because of hypoxia, which is going to be a very serious condition, healthcare problem nowadays. So you have ocular problem and thermological problem, cardiovascular, if you are taking arrhythmia, myocarditis, pericarditis, acute coronary syndrome, and heart failure, which is going to be a next problem, and renal failures. We don't know now. Oxygen, government has supplied enough, enormous. They have taken more. Once it is coming to renal and more with black fungus, and that is the drug that we are using, ambutation, is going to be the nephrotoxic. Now, where we will go for this type of dialyzer and different type of things, there is no plan in our government or in our healthcare systems. Keeping all these things, we want to keep this one as one of the topic, and I know many of the people are going to speak about it. And researchers are learning about the effects that may persist after patients are recovering from COVID-19. All of you know, LIT 100 is the maximum drugs what we are giving, which is going to reduce our immunity. So that's why we are getting more fungus diseases and more fibrosis and more other problems like nephropathy, neuropathy, like that. So to reduce that one, only thing is we have to prevent the third wave, which are going to be the best. Healthcare workers and researchers are on the front line fighting COVID-19, hoping to slow the spread of disease and care of the sick by social distance, wearing the mask, wash your hands frequently, and once you are coming from outside, you wash your take bath and away from your children. Once you are having symptoms, immediately report to the hospital and go for checking. That is screening. Wherever you are going, it is better at least go for rapid test, which will be helpful for you. And don't hesitate to take vaccination with or without COVID, morbid diseases also you can do. So maintain these 10 things to reduce your third wave, which will be going to be the thing which is going to be taught, teach, and we are going to discuss in detail, which will be helpful for our community as well as to our society. So this is another how we are reducing our immunity. So vaccines train your immune system using a harmless form of the virus. Whereas some of the time, it is harmless, but it is causing your thrombosis in our body. That's why some of the people are getting complications of vaccine, that is thrombosis induced myocarditis or myocardial problems. So it will adopt your immune response. Once your body is adapting to immune response, then you will be having B cells that make highly specific antibodies that will reduce our entering of the coronavirus. T cells will help to stimulate the T cells and kill any infected cell. So we will have long-term immunity. So here we are telling what are the things we have to do. I have oriented you. As time is running more, I am going to complete it. I believe and I assure you this conference will give you a great change of knowledge in many areas, clinical sequelae of 19, as we are all first line corona warriors. With this knowledge will help you to practice in the hospital as well as in our community. Once again, I welcome all our participants to this conference, and take home message is that it is not only for others, it is for us also. That is always maintaining the social distance, wearing the PPE properly, wash yourself properly, and once you are going home, please be quarantine yourself and make your health maintain your health properly. Take immunity enhancing foods more and be safe. So we are losing many nurses. We don't want to hear that one also. Wish you all the best for attending this conference, and I wish you all be safe during these periods. Wish you all the best. Once again, I welcome all of you. Thank you for giving me this chance. Thank you, ma'am, Valli ma'am, and Florence sister, and others also, those who are coming for this conference. Thank you.
For
Thank you,
giving
madam.
valuable insight on keynote address. Now let me hand over the mic to Smita ma'am for best part of the session.
Can I stop my share?
Yes, ma'am. Yes, ma'am.
Thank you.
Now, let me introduce Dr. Vasanta Kumari ma'am, Associate Professor from Institute of Health Sciences, Wolaga University, Ethiopia. With 22 years of rich experience, 31 credentials and achievements in the special expertise area of co-curricular and curricular activities. She has 34 publications in various national and international journals. Madam has also completed more than 800 community and professional engagement services under Wolaga University. She performed various roles in many conferences as chairperson, jury member, and guest speaker. It's my honor to welcome you, ma'am, for today's presentation.
Thank you so much, Smita, for your wonderful introduction. Short and sweet. Thank you. So let me start my presentation. Can I start?
Yes, ma'am, you can start.
Okay. Oh, please, kindly can you enable the screen sharing because it's disabled. I think screen sharing is disabled.
Yes, ma'am.
Smita, can I share? Can I share from my end?
Yeah, from your side you can share, ma'am.
But it's not, I'm not able to share because I think it's disabled by the host.
Just a moment, ma'am. We will rectify that one. Just a moment, ma'am.
Ma'am?
Yes, Smita.
Is that possible for you to share it now?
No, it is host is disabled only it comes.
Shall we do it from our side?
Yeah, try it. Okay. Why can't you because it will be easy, if I am able to do it.
Yes, that's one.
Ma'am, just a moment, madam. Our technical person will do that, madam. Just please give us a moment.
No problem. No problem. I'm waiting.
Yes. It's done. Done.
I think I can do that. I'm able to do it. I'll.
Now you try, ma'am.
Yeah. I think this. Is it visible?
Yes, ma'am. It's visible.
Okay. So thank you. My wholehearted warm greetings to Narayana College of Nursing, Nellore. I think this is the second chance, golden opportunity given by Dr. Indra Madam. And I'm very much privileged to be a part of this conference and also part of the institution. I know it is at par excellence. The institution is at par excellence with all the stalwarts who is the stalwarts and the leadership of Dr. Indra Madam and all the faculty members. And it's a great opportunity. So with this, let me start my presentation because my area is like a network resource poor area. So kindly bear with me if there is any network interruptions. And also because it's a very early time for us. So I'm sitting at home and doing this presentation because it's very early because 2.5 hours we are behind Indian time. Also, I just wanted to tell you all that kindly bear if there is any other interruptions and any other because from since yesterday night, I'm not feeling good. I don't want to tell this to Smita because I was having a fever and I don't know. So if there is any problem with my voice or something like that, kindly bear with me. I hope I'll justify this opportunity that was being given to me. Thank you. Thank you so much. So the clinical sequelae of COVID-19 survival womb to tomb. Very beautiful topic. That's what I wanted to tell. Very attracting as well as it is some kind of mesmerizing topic. I don't know who has selected this. Hats off to those persons. And my topic is epidemiology of COVID-19 in second wave. So we all know the first wave, we know what was the surge, but now the second wave is almost over and we are expecting the third wave again November to December. So, but we need to know the epidemiological aspect. I think so all the stalwarts who spoke before me, Dr. Valli Madam and Dr. Indra Madam, and they have just touched a small part of this epidemiology. They have told about the statistics, what is happening. And I just wanted to give a small little bit of detailed version of this. So before going to that, I wanted to render my heartfelt gratitude to the management, principal, vice principal, organizers of Narayana College of Nursing, India, and Dr. Indra Madam, Dr. Rajeshwari Madam, and Smita, and all other organizers. Hats off for your great initiation and organization. I know very well about Narayana Institution organization. Nothing we can tell about this because it's been well developed. Okay, so it is a part excellent institutions. So nothing to tell, but again, it's another feather to be added on into the cap of Narayana institutions. That's what I can tell. And I wish and bless more and more accomplishments and achievements of this particular institution. And also, I thank my own management, dean, HOD, and faculty of Institute of Health Sciences, Volaga University for the support and encouragement at all times. So with this, let me start the introduction. So COVID-19, we all know it is an infectious disease, which is posing a massive challenge to the global health. And coronaviruses are very important human and animal pathogens. And the name itself, we know, it is derived from the Latin word corona, that means crown. So the name refers to the unique appearance of the virus because under the electronic microscope, we see it is like a round particle with a rim of projections that is going to resemble a solar corona. So coronavirus 2019 is an infection which is affecting the respiratory system. So it is a respiratory disease that is caused by novel corona. It's the new coronavirus. It's called as severe acute respiratory syndrome coronavirus 2, because already we had a SARS-1. So this is a SARS-2. So it was previously it was referred as 2019 new CO, that is NCO. And WHO, which just learned this new virus on 31 December 2019, which is evidenced by the report that is being got from the viral pneumonia cluster of cases that is from the city Wuhan. And we all know very well, it is in the site, it is in China, and where the start of this particular virus has been initiated. So it's rapidly spread, resulting in epidemic. So initially it was an epidemic in China, and it has become a global pandemic later on. So in February 2020, WHO designated the disease COVID-19, and it is actually called as coronavirus disease 2019. So the epidemic has escalated and rapidly is spreading around the world, with the WHO first declaring the public health emergency of international concern on 30 January 2020, and then formally they have declared it as a pandemic on 11 March 2020. And we all know the origin of virus. The origin of virus, actually, it is from the seafood market of South China, that is Wuhan and South China. So where there is live animal or wet market. So we know the disease, actually, it was a zoonotic origin of virus. But still it is unknown, because there are a lot of researches that has been conducted. Still the researches are going on, and still we are not able to get the proper evidences. So in the first 424 confirmed cases, they found that 55% of cases before 1st January 2020, it was mainly linked to this market. But after this, 8.6% cases only are linked to the market. So we don't know. So it is mainly a person-to-person transmission. That's what has been it has been evidenced. And also the human airway epithelial cells, that is mainly they've taken this to isolate the virus, and they have found out this virus, and then only it was declared. And this suggests that person-to-person transmission was it is very high, and especially with the close contacts. So that has been occurring in the middle of December 2019. So some studies suggest that SARS-CoV-2 may be a recombinant virus, that is between a bat coronavirus, and also we know the origin unknown coronavirus. It may be between that. And so many are telling it may be bat, but also other animals like pangolins and minks. So the minks is a very common one. That's what the lot of the researchers that is being found. They say minks are the common animal which can cause a infection. That it can transmit the infection very easily from animal to human. That is from mink to human is very, very common. So on when we talk about the geographic distribution, on January 11, the first case was reported outside mainland China, that is in Thailand. And within months, we can see that this is spread to all the continents except Antarctica. So India reported its first case of COVID-19 on January 30, 2020, and this rose to 3 cases by February 3, 2020. And by mid-March, the number of infected cases, they started to increase, and many cases were reported from all over India. And the first COVID-19 related death in India was reported on March 12, 2020. And by the second week of April, the disease spread to all the states in India. That was the first wave. And also we can see the counts, the case counts. So over 173.6 million cases have been reported globally, with approximately 3.7 million deaths according to World Health Organization. That is the updated version. And US has the highest number of reported infections and deaths in the world. And it has been followed by India, Brazil, France, and Turkey. So the reported case counts underestimate the overburden of COVID-19, because we know only a fraction of acute infections are diagnosed and reported. So still now this is a dilemma. So we don't know what is the issues, but we don't know how many testings is being done, how many, because without that confirmation, we cannot properly go with the statistics. And we can see this is the order. So United States, India, and also we can see the Brazil, France, and Turkey. So coming to India, in India also, the surge is very commonly occurring in 5 states. So the leading one is Maharashtra, then Karnataka, Kerala, and then it is Tamil Nadu, and last it is Andhra Pradesh. So the COVID-19 second wave, so that is what we are all thinking. What is that? What is that? And we have seen it actually, but we all know what is it. But we know what is the prevalence. So when you talk about the pattern, so far it's mainly increasing cases of COVID-19. We see the surges in the summer, as well as we can see more in the fall season too. So some locations, that is, they saw a higher number of coronavirus infections early on, followed by a decline. So that is like initially they say first wave, the countries which have not even seen the first wave, but they were able to experience the second wave. That has happened even in Ethiopia. So in areas where fewer people are wearing the mask, and also we can see the like people are like they are going for the gatherings in the indoors to eat, drink, observe religious practices, or celebrate and socialize, or even with the family. So the cases are rising. So that is according to Lisa Maragis, so who is an infectious disease specialist at Johns Hopkins Medicine Hospital. So he is declared this. And also we can see the surge, why the surge and spike in second wave is occurring. So the driving surge is because of that is mainly it's like a wildfire. So that is the reasons are because in early 2020 it started with a very small number of infected people, and then it started to spread. And disease is widely spread with many unknowing coronavirus carriers. We don't know how many are carriers, and they are able and they are traveling and they are going across the different parts of the area, and the risk of transmission is widespread. So we all know the lockdown was there, but still there was some kind of relaxation because of the economical issues and other issues. So this again, it was a opportunity for the virus to spread again. So also after many months of cancelled activities, economic challenges and stress, people are frustrated and they are very much tired of taking the coronavirus precautions. So we know Dr. Indra madam and Dr. Valli madam was going on insisting SMS, and they were telling we have to follow this. And many WhatsApp also we can see we have to follow women, don't follow men. So they were given very much precautions like maintain the social distance, wearing the mask and all that. But we know we are talking so much, but we are not able to even as a healthcare people also. Oh, we completely wearing this. I think this is a very challenging to even going with the PPE and also strictly adhering to this. And also the second wave would have been triggered by a few newer strains of coronavirus. That is a very important reason because there is called as UK virus, South Africa virus, and also there are many double mutants. And also we have the virus in the India also. So these mutants of coronavirus are very infectious and they have more of R value. That is the number of people who are infected, they can transfer it to other persons. From one person to another, it can move very easily. And people's apathy mainly towards the precautions for corona, like wearing the mask, not washing the hands, not using sanitizers properly, that is called as pandemic fatigue because they are very tired. And also we can see there is large scale congregations, especially we all know very well now there was election season as well as there were a lot of ceremonies like wedding ceremonies, sometimes deaths and all this. So people are gathering, we cannot avoid this. Also, more than 1 year since COVID-19 was declared as a pandemic, the deadly SARS-CoV virus continues to disturb the public life across the world. And this public health challenge, we know it is appeared to due to the mutations, because we know no, the second wave is mainly because of the mutation of the SARS-CoV-2 virus, so which has become very contagious. And India is currently going through the second wave of COVID-19, though there is a decline that is coming, but still it is there. So the virus is said to be more infectious than it had occurred previously in the second wave. And we can see this when you talk about the second wave, we know there is lineage B1.1.7. So this is actually it is a type of mutant which is being detected in United Kingdom in November 2020, and it was estimated that 40 to 80% it was that was transmitting the infection. Similarly, the strains from South Africa, that is B1.351, and also it is from Brazil and India also, there are significant mutants that can also cause that is very much contagious. And also we can see there has been like as of April 14, 2021 data from our world in data among the countries shown, the United States has a maximum cumulative cases with a total of about 32 million, followed by India. And so also in comparing the epidemic growth, we can see India is because of the epidemic growth, as madam also was they were insisting on this, India is showing a tripled number of cases compared to US. That is mainly because of this curve. And also the US had the first peak in mid-July 2020, which was following with the cases subside, then it got subsided. And infection counts that started to increase in October. And also we can see there was a larger peak in second wave in December 2020 with the daily cases that was going up to 0.25 million. So in UK, the first and second peaks were separated for a couple of months, with the second wave larger. Mainly it is attributed to more infectious mutant. And for Russia, the infection curve is relatively shallower, with the number of daily cases never crossing 30,000. In the curve for Brazil, there are large fluctuations, which may be due to insufficient testing, because we know, however, the number of deaths per infection is also increasing. And the case fatality rate is also very large. The curve for the death cases typically is following the infection rate. So the CFR, that is the case fatality rate, was very high at the beginning of the pandemic for the US and European countries. And for India, we know the first and second wave, that the separation was about 5 months. The peak of the first wave was in September 2020, with the daily cases of around 0.1 million. And also we can see the daily cases decreased until mid-February, after which again there was a sharp increase. And the end of the first wave, we can see it was likely a result of the combination of many factors, because it was an effective implementation of government interventions, increase in awareness, and also very importantly, we can see the experience gained by the medical professionals in treating the diseases over the initial months. So they have started to become more experts. They started to handle the cases. So we all know, even the second wave also we see, when the oxygen, there was a demand for the oxygen, and we know ventilator demand, and so many problems had come, and we all, mucormycosis, that was the other complication. We all talk about the black fungus, white fungus, yellow fungus, and so many problems started to occur. So what is the thing is, now little bit the surge is reducing. It's mainly because of this, particularly the frontline workers, because of their main thing, because what they have done, that is the main reason. And also when we talk about this, we can see the regional distribution. What we can see in the cases, what we can see is mostly what is happening. The COVID-19 spread further, that is going to characterize the second wave. The daily number of cases in Maharashtra, it is leading in the daily as well as cumulative infections. So we can see it is daily cases of 652 on February 11, 2021 to about 63,000. That is mainly when we talk about this. 63,000 in 2 months, we can see. Also in the first region, until the first week of March, all the states except Maharashtra, they exhibited a very slow increase only. But in the second region, most states, they started to show the spurt in the number of infections, propelling India's total daily count to about 0.2 million. And the characteristics of the second wave, mostly the new mutant, it is very contagious because it started to dodge the antibodies, what that has been formed. Also, 18 to 45 age group who supposedly has strong immunity is very much susceptible, because they are called as super spreaders, because they can go out and they can come, and because we cannot control them, because this is a very active group. So most of the time they can even transmit. And this new COVID-19 strain is also infecting the children. And also when you talk about the virology, so this is very important in epidemiology, because it's this coronavirus is a large family of enveloped positive single-stranded RNA virus, which was first isolated from human in 1965. And it is a SARS-CoV-2 belongs to Sarbecovirus subgenus. And it is the family is Coronaviridae family. And it is the 7th coronavirus known to infect the humans, which produce mild respiratory diseases. And the virus has been found to be similar to SARS, like coronaviruses from the bats, but it is different from SARS-CoV and MERS-CoV, we all know. And that is Middle East respiratory syndrome and severe acute respiratory syndrome infections. And the virus, when observed under electron microscope, had a diameter of 60 to 140 nanometer with the characteristic spikes, that is 9 to 12 nanometer, similar to the Coronaviridae family. And 3 major coronaviruses leading to disease outbreaks, beginning with severe acute respiratory syndrome, that is in 2002, and it has been followed by Middle East respiratory syndrome, that is in 2012, and now severe acute respiratory syndrome, coronavirus 2, that is designated and proposed, the name that has been designated by Coronavirus Study Group of International Committee on Taxonomy of Viruses. Others also present, that is circulating among the mammals and birds, but that is not affecting the human. And also coming to the emerging SARS-CoV-2 variants, all viruses, including SARS-CoV-2, they change over time. So over 490,000 variants of virus have been sequenced by COVID-19 Genomics UK Consortium, that is as of 3rd June 2021. And WHO also has introduced in very easy to pronounce and non-stigmatizing labels, that is based on the Greek alphabet, that we can use for the COVID variants, that is very common during the second wave. And full genome sequencing and phylogenetic analysis, that is indicates that the coronavirus that causes COVID-19 is a beta coronavirus in the same subgenus as the severe acute respiratory syndrome virus is, but mostly we can see it is in a different clade. It is coming in a different form, different mutation. And the closest RNA sequence that is similar to 2 bat coronaviruses, and it appears likely that the bats are the primary source. But still it is unknown. We don't know. Still the research is not yet proved that the bat is the source of this, primary source of this. Also, the host receptor for SARS-CoV-2 cell entry is the same for SARS-CoV, the angiotensin converting enzyme 2. And also the CoV-2 binds to this ACE2 through the receptor binding gene region of its spike protein. That is why this second wave has become very common, because as this spike is very thicky and thick, and it is also very thick in consistency and very sticky. What happens is when the virus enters, straight away it is affecting the pulmonary lungs, and it is causing a pulmonary sequelae. And the cellular protease, that is TMPRSS2, also appears important for this cell entry. And also early in the pandemic, a study that is monitored amino acid changes in the spike protein of SARS-CoV-2 included in a large sequence database that identified D614G, that is glycine for aspartic acid substitution, is also very important. That is also causing a dominant polymorphism globally over time in the second wave. And SARS-CoV-2 variants of concern. What is the mutants? Because we all know it's a mutation is changed, but there are 4 mutants, and one is alpha, beta, gamma, and it is called as epsilon. So let us see what is the alpha mutants. And if you see, this is actually identified in Kent, southeast of England in September 2020, and it has been reported by WHO in December 2020. But we don't know, the origin is not very clear, and the variant is reported in 137 countries, and community transmission has been reported in 35 of these countries. That is as of 19th April 2021. And also, when we talk about this, temporarily associated with increase in regional infections, and this variant contains more than a dozen mutations compared with other circulating strains with several within the spike protein. So that is a very important aspect of this particular mutant. And secondary attack rates also been reported to be higher index. Also, the reported secondary attack rate is 10% in context of people with the variant who have not traveled. So we all know the first wave, mainly it was a travel history, but second wave, without any travel itself, the surge of the infection was occurring. And also, there is evidence that there is no increase in reinfection rate, and that vaccine performance is preserved against this variant. And the variant has mutations that has been associated with attenuation in other variants, and 50 to 75% it is transmissible. And also, a report from Public Health England found a secondary infection rate of 12.9%. And coming to the mutations in the variant, we can see there is another one mutation that has come from this. That is the N501Y. So it is actually receptor binding domain of the spike protein, and it also increases the infectivity. So another spike protein mutation is P618H, and that is actually, it is having a cleavage site, which is very easy for the cell entry. And associated with the greater disease severity, the risk of mortality is also more in this particular variant. So next, also we have the genomic analysis of this particular variant that is being seen in United Kingdom. Also, it is also affecting the USA. USA also being affected by the same variant. So another mutation in this variant is also a deletion of spike. That is, we can see it is 69 to 70 deletion is being present in the genomic study. Also, there is another one that is S gene target failure. That is also a marker that is being found in this particular mutant. And coming to the Delta, that is another one, that is another variant. We can see this lineage also known as 20A, and it is identified in, this is the very common, it was seen in India, and now it is dominant in UK. So the both travel associated as well as locally acquired cases are rising in UK, mainly in London, Northwest, and also the east of England, and it is more transmissible than the previous variant, that is Alpha variant. And the secondary attack among the context of cases that have not traveled is 12.4%. So it is more than the previous one. And increased risk of hospitalization is also higher. And also we can see this has been reported in many parts of the country. And the infections caused by this particular variant, it has been increasing. And secondary household infection is also increasing because of this particular infection. And unpublished studies say this, that the vaccine effectiveness is for the 2 doses, that is the Pfizer vaccine as well as AstraZeneca vaccine, is very much high, more compared to the previous strain. So that is why we are more insisting on the vaccine for the people, because that will help in herd immunity, as well as 70% of vaccine when people are taken, we can protect the country. And also we can see there is a beta variant. So this is a variant that is known as 20H, and it has been found in South Africa. So it is detected in Nelson Mandela Bay in South Africa in October 2020, and it has been reported in 97 countries. It is including UK, and the variant has similar spike protein mutations like the previous one. And also the sequence analysis reveals that the N501Y mutation reported in UK and South Africa, it is originated independently. It is not from anywhere else. Also, we can see these mutations may affect the transmissibility and also antigenic profile. It also has the potential for increased transmissibility. It has subsequently identified in other countries like United States too. So this lineage contains another mutation in spike protein, that is E484K, which is a potential to impact the immunity as well as because before any infection or vaccination. So it is mostly going to affect the immunity. It is vaccine-induced immunity will be more protective against this particular variant. And coming to the gamma variant, this variant is called as 20J, and it has been identified in Japan. So it is mostly seen in 4 travelers from Brazil also, and was later reported to account for 42% of 31 sequenced specimens in Amazon. So the Amazon, Brazil, where this is a particular strain that has been seen, and the variant has been reported in at least 55 countries, that includes UK and United States. And also it has several mutations, including 3 in the spike protein receptor binding domain. So that is N501Y and E484K and K417T. So it has a potential for increased transmissibility and impact on immunity. And coming to epsilon, that is the last mutant. So here this is also known as 20C, and it is detected in Southern California, USA. And by January 2021, the variant accounted for actually 35% of viral samples that has been sequenced in California, and it has been identified even in other countries. So the variants contain several spike protein mutations, including L452R, and that has been associated with the increased cell entry and reduced susceptibility to neutralization of the convalescent and vaccine recipient plasma in utero. So we all know very well the neutralization is completely reduced in this particular mutant. So these are the very important dangerous mutants that has been the very important cause for this particular second wave. The variants are also associated with 2-fold higher viral RNA level that has been found in the nasal swabs when it compared to the wild type virus, the previous viruses. And also they have increased risk of transmission that can cause severe diseases. Also they respond that may not respond to many the proper treatments too. So coming to the transmission dynamics, so we all know the respiratory transmission, that is a very common one, that is a dominant mode of transmission because of the proximity and the ventilation, and that is a key determinant of the transmission risk. So the route is mainly person-to-person transmission. So direct or indirect or close contact with infected people through the infected secretions like saliva, respiratory secretions, or through the respiratory, mostly if you see, it is respiratory droplets which are expelled when an infected person sneezes, talks, or sings. And close range contact, if you see, it is mostly, you can say, approximately 6 feet of 2 meters via respiratory particles. Virus is released in the respiratory secretions that can infect another person if it is being inhaled, or it may be because of the direct contact with the mucous membranes. And also, if you are going to touch the person's hands, which has been contaminated, it is being touched. So by the secretions or by touching the contaminated surfaces and touching the eyes, nose, or mouth, the chances are common. Also, the transmission can be through the longer distances through the airborne route, but still this is also not well defined. So through the inhalation of the particles that is remaining in the air over time and distance. So the scattered reports, outbreaks, what they say is, especially in the restaurant or in a bus, they have highlighted the potential for longer distance airborne transmission. Also, it is enclosed, like mostly it is an enclosed area, or also in a poorly ventilated spaces. This is very common. So studies using the specialized imaging to visualize the respiratory exhalations have suggested that respiratory droplets may get aerosolized, or it can be carried in a glass cloud and have horizontal trajectories that is beyond 6 feet also. So we are always still maintain a 6 feet distance. Sometimes the chances beyond 6 feet is also may be present because of the aerosols. So like when you have somebody speaking, coughing, or sneezing, the particular virus droplets could be present, and that can cause this particular, it can transmit the infection. Other studies have identified the viral RNA that is in ventilation system in air samples of hospital rooms of patients with COVID-19, that includes patients with mild infection. And airborne in transmission, if you see, it is very common in healthcare settings because aerosol generating procedures are done there only. So where we are going with 80 intubation, or we are going doing a ventilator, has been support is being provided. So possible the community related to enclosed door, crowded spaces with poor ventilation, where the infected person may be breathing heavily. So especially in the restaurants, choir practice, fitness classes, like gyms. So the risk of transmission is much lower outdoors compared to the indoors, with a limited number of studies estimating the transmission rate of less than 1%. And fomite transmission. So the direct transmission with the fomites, the virus has been found to be more stable on plastic and stainless steel up to 72 hours, and compared with the copper, that is up to 4 hours, and cardboard up to 24 hours. So in healthcare settings, the virus is widely distributed in the air and on object surfaces in both general wards and intensive care units. And transmission, when you talk, the virus also is being detected in blood, cerebrospinal fluid, pericardial fluid, pleural fluid, urine, semen, saliva, ocular tissue, including the cornea, tears, as well as conjunctival secretions, as well as in the middle ear and mastoid. So when we see all this, because we know only respiratory, when I was going through all this, it was really, because still it is not, the evidence is not properly produced, but still this This is the statement that has been made by some of the epidemiologists. So the presence of virus or viral components does not, we know that it is not going to equate with the infectivity. And the fecal-oral transmission, that is mostly this particular way we can see this. So, or respiratory transmission through aerosolized feces, that is maybe possible. So the pooled detection rate of fecal SARS-CoV-2 RNA in patients with COVID-19 is approximately 51%, with 64% samples remaining positive for a mean of 12.5 days. That is up to 33 days maximum after the respiratory samples became negative. So even if their respiratory samples are negative, still the person can be positive when we take the fecal strain. And scattered reports of clusters in a residential building and in a dense urban community with a poor sanitation, it is suggested that the possible transmission may be because of the sewage drainage, that is improper one. Also, the transmission through the other body fluids, sexual transmission or bloodborne transmission, that is not been well reported. So likelihood of bloodborne transmission through blood products or needle stick appears very, very low. And also it is not sexually transmitted, but may have an effect on the male infertility, but still the evidence is being collected in this space. Also, there is no evidence that it can be transmitted through contact with non-mucous membrane sites, that is abraded skin. And vertical transmission, so we all know very well it occurs rarely. Transplacental transmission has been documented nowadays. So we know the children, infants born to the mothers are also few children are having, the percentage is very less. But so overall 6.3% of infants born to mothers with COVID-19 tested positive for the SARS-CoV-2 at birth. And transmission was reported in both preterm as well as full-term infants. And there is no evidence for antibodies against this SARS-CoV-2 among the infants who are born to the mothers with COVID-19 who tested negative for this particular infection. And the rate of infection appears to be no greater when the baby is born virginally, breastfed, or in allowed contact with the mother. So the viral fragments have been detected in breast milk. It has been associated with mild symptoms in infants, and anti-SARS-CoV-2 antibodies are more prevalent in breast milk compared with the viral fragments. And nosocomial infection, so that is very common. So we all know still the mucormycosis, they say it is because of nosocomial transmission. So it is accounting for a nearly 35% increase in some areas. And studies say healthcare workers are exposed to the index cases. They found little to no nosocomial transmission, and when the contact and droplet precautions are used. So proper PPE use truly it is going to control this particular transmission. And transmission that is related to symptoms, we see symptomatic transmission, transmissibility, it's mainly depending on the amount of viable virus that is shed and expelled by a person, that is called as viral load. So when you talk about this, it is mainly first 5 to 7 days of illness, the viral load is highest, and the type of contact, the setting where it is occurring, and what infection prevention and control measures are in place, that is very, very important. That is why, because it depends on the population, it depends on the setting, it depends on the, depends on the proximity. So that is why some states, which is having a large number of population as well as it is more dense and all, so that is why it has been most of the metropolitan cities are affected. And asymptomatic transmission, the transmission from asymptomatic cases, that is lab confirmed cases who are not developing the symptoms have been reported. So we know very well this is very dangerous because they are the super spreaders. So the overall estimate of the proportion of the people who become infected and they are symptomatic through the infection has been estimated to 17% to 33%. So these 33% are only causing 80% mild infection in others. And also healthcare workers may play a role in asymptomatic transmission. About 7.6% of healthcare workers who worked in hospital units with infected patients are tested positive and they have the antibodies. However, only 58% of these workers reported the prior symptoms. So children are more likely to be asymptomatic. And also when we talk about the asymptomatic or pre-symptomatic transmission, symptomatic, that is the transmission from individuals with infection, but there is no symptoms at all. So transmission may occur during the incubation period, 1 to 3 days before the symptom onset, and the risk of transmission from an individual who is asymptomatic appears less than that from who is symptomatic. And also we can see the CDC modeling study, they estimated that 59% of transmission could be attributed to individuals without symptoms. So 35% from pre-symptomatic individuals and 24% those who are remain asymptomatic. So they are very dangerous. And super spreading events, this is another transmission dynamic. So these events are associated with explosive growth early in outbreak, because we can see this is in the later stages, the transmission was mainly because of the super spreaders. So they reported that church, religious gatherings, family, social gatherings, weddings, choir practices, overnight youth camps, or high school retreats, or fitness classes, indoor recreational sporting activities, business conferences, and working in call centers all were the main source for the super spreaders. So we know even the IPL match that was ongoing very well in India, suddenly it got cancelled because there was a spread of infection among the players too. So these type of gatherings can cause these problems. Also, this widespread transmission can be reported in long-term care facilities, homeless shelters, prisons, immigration detention centers, and meat and poultry processing facilities, also in the boat cruise ships. So limited transmission is reported in childcare and school and university settings, and infected cases may transmit the infection to the household members. So some individuals are super spreaders, shedders of virus, because they are not spreaders, but they are shedders, because that is because of the behavioral, host, or environmental factors. And when we talk about the widespread transmission that is being reported in long-term facilities, mostly we can see like the homeless shelters and prisons, immigration detention centers, we can see. And also this mainly these people or these areas is a very important area where the spreading is going to be a very important, massive spreading is going to occur. So we all know the schools, childcare settings, and university settings are very limited transmission because the children are not, they are mostly asymptomatic, and also the prevalence of infection in children, the rate is very less. As well as when you talk about this, because of the lockdown measures, we all know the strict lockdown is being followed for the school settings, education settings. That is why the transmission is also very much limited. And incubation period, we can see the factors.
Dear participants, I think little network issues are there with the Central Command website. I request you to spare for a few more minutes. So I need to
Hello? Hello? Hello?
Ma'am, we could hear you, ma'am. We could hear you.
Yes, ma'am. Yes, ma'am. Yes, ma'am. You continue.
My apology to the participants. Let me continue. Again, I think it's disabled. Can you enable the share?
Yeah, ma'am. Definitely, ma'am.
Yes,
Definitely.
yes.
So, done.
Ma'am, share.
Yeah.
Ma'am, you can share it from there.
You can see
No,
your
it's coming as disabling the host is disabled.
Just this. No post is this.
Yes, ma'am. Yes, now you can do it, ma'am.
Okay, thank you. Okay. I'm sorry, extremely sorry. I think I was in the transmission phase, if I'm not mistaken.
Yes,
Where
ma'am.
did I
You continue. Yes, yes. Continue.
I stopped in the transmission area.
Yes, yes, yes.
Okay. So we have seen with the variants, that the mutants, that is going to cause the transmission factor. So here we have seen a lot of transmission dynamics, how it is being transmitted. Also, we have seen presently the fecal-oral transmission. That's why we have seen the GI symptoms too. And with this, we have seen about other transmission factors, where we have seen the dynamics like asymptomatic transmission. And also we talked about the super spreading events, those who are going to spread. So people who are going for the gatherings, especially youngsters, and 14 to 8, the people who are from mostly from 18 to 45 years of age group who are active, they can spread very easily. Also, the widespread is going to occur in many areas, and low spread is seen in schools and university settings. And also, when you talk about the incubation period, we told it is between 1 and 14 days with a median of 5 to 7 days. And the viable virus is actually is going to be very short-lived and infectious. Mostly, we can see it is going to be a infectious peak that is going to be around 1 day before the symptom onset, and it is going to decline within 7 days. So the pooled mean incubation period is 9.6 days in children. As well as we can see the reproduction number, the number of people who is acquiring the infection from an infected person is estimated to be 2.2 to 3.3, and this is very high heterogeneity across studies, and the number varies between the countries too. And also we have to talk about the serial interval. So the time between the start of symptoms in the primary patient and the onset of symptoms in the patient being infected in a chain of transmission, and that is approximately 5.45 days. And similarly, secondary attack rate, that is very common now, because that is what we can see. So the secondary attack is the proportion of people exposed to the index, that is our primary case, that can go on develop the disease as a result of the exposure. So the pooled secondary attack rate, that is been estimated to be 7%. And second, when you talk about the secondary attack rate, mostly it is familiar prolonged contact increases the potential for transmission. Mostly we can see this is mainly seen in the household. So where it can be because of the strangers or the family or the friends, and 1.9% in the workplaces, and 3.6% in the healthcare facilities, and 21.91% for household settings, and that is going to increase with the exposure of more than 5 days. Am I audible? Am I audible?
Yes, ma'am. You are audible.
Thank you. And also the secondary attack rate, if you see, it is going to be increasing with the severity of the index case, and children aged more than 5 years, they have a low secondary attack rate compared with the older children, and the risk of infection is very much higher in the household index, especially from the mother, they can get very easily. And coming to the viral load, we know very well this is very common, especially in the respiratory tract, nasopharynx and oropharynx has been affected, and during the peak in the first week of illness, it has been present, and it increases the lower respiratory tract. Mostly we can see that it's been seen in the sputum too. So the viral load decreases after the symptom onset, and patients with severe disease have higher viral load compared to those with mild disease. And the viral load appears to be a leading driver of virus transmission, and higher viral load in swabs of asymptomatic contacts is really associated with the higher risk of developing the symptomatic disease, and these contacts had shorter incubation period than those with a lower viral load. And viral shedding and period of infectiousness, that is very important, because the precise interval during which the individual with the SARS-CoV-2 infection, they can transmit the infection to others is uncertain. The mean duration of shedding was 17 days in the upper respiratory tract, 14.6 days in the lower respiratory tract, and 17.2 days in the stool, and 16.6 days in the serum samples. And also the maximum duration of shedding was 83 days in the upper respiratory tract, So this is very common, very commonly we can see. And when we talk about this particular one, we can see it is 59 days, it is seen in the lower respiratory tract. That is the maximum duration. And 126 days also it can be present in the stool, and 60 days in the serum sample. That is why even if the respiratory tract is, when the samples from the respiratory tract is showing negative, still in the stool it has been present. And also no live virus has been detected beyond the day of 9 that is of the symptoms, despite persistently high viral load. And duration of viral shedding was longer in symptomatic patients compared to asymptomatic patients, and in patients with severe illness compared with the non-severe illness. And also factors associated with the prolonged viral shedding, mostly we can see male, sex, older age, comorbid illness like hypertension, delayed admission to hospital after the symptom onset, or severe illness on admission, and use of invasive mechanical ventilation or corticosteroids. And also it is very common with the immunocompromised patients because they can shed even up to 2 months. And viral transmission factors, other factors we can see, it is period of greatest infectiousness. So mostly you see this infected individuals are very contagious in the earlier stages when the viral RNA levels from upper respiratory specimens are very high. And similarly, prolonged viral RNA detection does not indicate prolonged infectiousness. So the duration of viral RNA shedding is variable and may increase the age and severity of illness. That is why the quarantine measures, the lockdown measures should be strictly followed by the people. And also the risk of transmission depends on the exposure type. So it varies with the type and duration of exposure, use of the preventive measures, how much, and also risk of transmission after contact with the individual with the COVID-19 increases with the closeness, mostly proximity and duration of the contact, how long they are contacting, and also the prolonged contact in the indoor settings, that is very highest. And also what are the other the risk of transmission, what are the factors it is depending on. Mostly if you see, it is household settings, in healthcare settings, mostly within personal protective equipment is not used, it's not available more in some areas. And also congregate settings where the individuals are residing or working in a close quarters, like cruise ships, homeless shelters, detention facilities, college dormitories, and food processing facilities like canteens. Also social or work gatherings, that is highlighting the closeness. Also non-household social contacts, restaurants, drinking, eating establishments, bars, and traveling with the individual. So that is also it has also high risk exposure. So they found a study in that 62% attack rate among the passengers who are sharing the business class cabin. So they were sat like they were 6 feet apart, but still the transmission was highest in the flight. As well as in China, when they did a study for the passengers who were traveling the train, who are being exposed within 3 rows, they found the rate was nearly 0.32 overall attack rate. And the risk of transmission with more indirect contact is very much like it is not that well established, and it is very likely to be very low. And coming to the environmental contamination, we know virus is present on the contaminated surfaces, and the susceptible individuals, so if they are touching the surfaces, they can transfer the infection to other areas. So Singapore, they've done a study. So viral RNA has been detected on nearly all the surfaces like handles, light switches, beds and handrails, interior doors and windows, toilet bowl, sink basin. So in the airborne infection isolation room of a patient with symptomatic mild COVID to routine clinic. So we have to be very careful. And risk of animal contact. So they say there is no that much evidences that suggest this. And coming to the immune responses following the infection, mostly we know SARS-CoV-2 specific antibodies and cell-mediated responses are induced following the infection. These responses are very protective, and at least for a few months, it is going to give the immunity. Similarly, humoral immunity, if you see, it is following this SARS-CoV-2, the majority of patients develop detectable serum antibodies to the receptor binding domain of the viral spike protein and associated neutralizing activity. And there is also cell-mediated immunity, that is because of CD4 and CD8 T cell responses that is being found in the patient who has been recovered from the COVID-19 infection, as well as because of the vaccine. So protective immune responses after infection or vaccination, that is also done in primitive studies. They have done in a lot of animal studies. They are found to be very positive. And also the risk of reinfection. The short-term risk of reinfection is also very common. So within the first several months after initial infection, that is very low. But after 3 months or 4 months, again, the chances is very common. So mostly they say the prior infection, that is reducing the risk of infection in the subsequent 6 to 7 months by 80 to 85%. So the estimated protective effect of previous infection is 80%. Age greater than 65 years are associated with higher rate of testing positive in both the surges. So old age people are very risky group. And also, and when you talk about the pathophysiology, that is very common in this second search, that is second wave, angiotensin converting enzyme 2 receptor, because that is only very important, because that is only causing the cell entry. Cell entry is only because of this binding that is going to, because this is having the higher binding affinity is being present for this particular ACE2, and compared to the previous strain. Also, the SARS-CoV-2 spike protein is mostly can bind very easily and infect the human cells expressing the ACE2, and also it also down regulates ACE2, leading to a toxic over accumulation of plasma angiotensin 2, and that is going to cause acute respiratory distress syndrome and also fulminate myocarditis. That is why the symptoms is very common, severe respiratory distress. Organs that is considered more vulnerable to this particular COVID-2 infection due to the ACE2 expression levels includes lungs, heart, esophagus, kidneys, bladder, and ileum that is being affected. Also, extrapulmonary manifestations are also associated with this particular thing. So, at the Indra madam was telling, the fibrosis is very common. So, it is affecting the diaphragm, lungs, and diaphragm fibrosis, lung fibrosis, and myopathy is also present because of this. So, the very important one which people are forgo, they are not understanding what is the pathophysiology. That is mainly because of ACE2. That is a very important reason, because of the host entry is very, very common because of this. And it is also when we see, and this is the common one, which is because of this binding affinity only, the transmission has become very common during this particular search. Also, the transmembrane protease serine 2, that is also another one that is very important. And spike protein, when you talk about the spike protein, it is playing a very key role. And because the spike protein can damage endothelial cells by down regulating the ACE2, and also it can inhibit the mitochondrial function of the cells. And coming to the autopsy studies, they found in pulmonary, lot of these changes are occurring only in the pulmonary, mostly respiratory failure. Also, there is alveolar damage, capillary congestion, and also microthrombi that is being present. And hyaline membrane is all, and pneumocyte atypical hyperplasia is very common. And pulmonary artery obstruction by thrombotic material, that is macroscopic and microscopic levels, also been identified. And also other findings like bronchopneumonia, pulmonary embolism, alveolar hemorrhage, vasculitis, and also new blood vessel growth that is through intussusceptive angiogenesis, fibrotic lung disease for which lung transplantation is also opted. And neurologically, we can see the changes, that is hypoxic changes. Madam was telling, and Indra madam was telling, there are a lot of people are there coming with confusions, delirium. So this has become very common in this case. And also cardiac patient, that is it is affecting the myocardium. And also we can see there is a cardiac dilatation, myocardial ischemia, thrombosis that is also common. Also it is causing pediatric inflammatory multisystem syndrome. So these children with COVID, children when they are affected, they have this particular problem which is very dangerous that can affect the cardiac. It affects the muscles. So the Kawasaki disease and this multisystem failure is also very common in children. And immunology, if we talk about that, we can see there is crosstalk between the immune system and hemostasis, and that is causing the thrombosis. So here also we can see there is aggregated neutrophils in the lungs, also in other organs, and neutrophilic plugs, that is the neutrophils and neutrophil extracellular traps, that is also aggregating, and the platelets also aggregating, and that is present in the heart, kidney, lung, and brain, and it is playing a very important role in coagulopathy, and also causes myocardial infarction, that is ST elevation myocardial infarction. And endothelial dysfunction, that is another problem where the coagulopathy, critical illness, and death is associated with this particular endotheliopathy and platelet activation. Also hyperviscosity is also another problem that can, so there is, it can damage the endothelium and causes thrombosis. And hepatic, it causes vascular thrombosis, hepatic cyanosis, also hepatic steatosis, congestion, and fibrosis that can be seen in the liver, as well as pancreatitis, pericarditis, adrenal microinfarction, secondary disseminated mucormycosis, which is very common now in the second wave, and brain microglial activation could occur. And also the genetic factors are very importantly playing a role. They say the males are at a high risk for infection, and they are having a poor outcome from because of this. AS2 and TMP RSS2 polymorphism is very much associated with the genetic role, and novel susceptibility locus has been detected at a chromosome 3p21.31 gene cluster. So in the patients, that is causing the respiratory failure. So these people also, they say ABO blood group system also playing a very important role. They get. And also the classification, we know, I'm not going to talk about this. It's we have the WHO has classified as mild illness, and also it is mostly we know they are going with a lot of symptoms, and also now presently the symptoms are this second wave, the symptoms are a little bit added. And also moderate diseases. So there only that we need oxygen saturation will be very less. And also when we talk about the children and adults, the pneumonia, there is a very common problem that could occur. And severe diseases, the clinical signs of pneumonia will be pleasant. Also, they have cyanosis, grunting, fast breathing will be there, chest in drawing, and danger signs is very common. They are not able to eat and they cannot drink. The children cannot breastfeed, and lethargy, tiredness, unconsciousness, sometimes convulsions, and fast breathing. And also, they'll go for critical diseases with complications like ARDS, sepsis, septic shock. Already I told what are the complications: thrombosis and multi-system inflammatory syndrome that can be seen in children. And coming to the clinical manifestation, so we all know very well the fever, anosmia, hyposmia, and loss of taste, sputum production, expectoration is more, rhinorrhea, nasal congestion, and arthralgia, myalgia, fatigue, anorexia, neurological symptoms, all with that. But what is the problem is ICU management for patients who developed this particular ARDS, arrhythmia, or shock is very common, and patients they need a treatment. And also the new symptoms here also I just go. So there is a GA system as GA symptoms, hearing loss, and also lethargy and weakness, and dry mouth are like there is a they won't have enough saliva. There is a reason they'll go with a lot of other problems like oral problems, and appetite is less. Sometimes the pink eye or conjunctivitis is very common, lethargy and weakness, and dry mouth. And coming to the diarrhea, headache, unexplained fatigue, hemoptysis, bronchial breath sounds, and tachypnea. And skin rashes, that is very common. And risk factors, old age group, and also we can see the cardiovascular diseases, diabetes mellitus, chronic respiratory disease, hypertension, obesity, and cancer that is being associated with this. And also many other things like contacts with confirmed cases, travel, residence, work area, that is more risky, male sex, ethnicity, and also long-term facilities, and blood transplantation, stem cell transplantation, Down syndrome, hemoglobin disorders, and other diseases like liver diseases, vitamin D deficiency disorders, proton pump inhibitor use, autoimmune diseases, Parkinson's disease, and physical inactivity, surgery, blood groups A and B, gut dysbiosis, and environmental factors. And host, we all know adults are affected, adolescent children are also affected, and pregnant women are more affected, which they can transmit transplants, and transmission is very common due to this. And healthcare workers, we are at risk because we are the frontline workers. We have to salute them because they are taking the risk only from the occupation. It's the occupation hazards. And measures is mainly we have to identify the source of outbreak and monitor and track the disease. That is very important. We have to go with the surveillances and study the diseases, and we have to go with the guidance for action. And we know very well it is a nationally notifiable disease. So the notification is very important. Then only we can take the action, and we have to collect information about the cases, and also contact tracing is very important. And you need to know what is the impact of diseases. So many the researches has to be conducted still more. So that is very, very important epidemiological measures that has to be followed. So as coming to the conclusion, the world is confronted with the pandemic from the new coronavirus. This pandemic and the measures taken in conjunction with this have a major impact on people and society, as well as care, cure, and well-being. Since the start of the outbreak, the coronavirus had led to a wide range of challenges for everybody. Knowledge, practical solutions, and research are needed to limit the negative consequences of pandemic. Though it is being conducted, but still it has to be conducted in an elaborative area. And public health measures such as social distancing, isolation, quarantine are needed to prevent the spread. And WHO recommends protective measures like frequent hand washing, avoiding touching of the eyes, nose, or mouth, and maintaining the distance of at least 1 meter between the people, and practicing the respiratory hygiene to help prevent the spread of diseases. And vaccine administration is very important and significant for the development of herd immunity that only can protect our country. So the strategies to increase the universal health coverage with massive infrastructural changes, upgradation of the public healthcare systems, and strategic involvement of the private health sector are required to rise up this novel challenge that the virus poses, with lasting benefits for both the current and epidemic and future health challenges. So with this, these are the references. Thank you so much for the opportunity given. I think it was a very elaborate, it was an extensive session which I have taken, and I was sorry for the interruption that has occurred because of the problem which is occurring in our area. Thank you. Thank you so much for the opportunity.
Thank you, ma'am. Thank you, ma'am, for giving in detail explanation of the epidemiology of COVID-19 in second wave. Thank you so much.
Thank you so much, Smita. Thank you, madam, and thank you, principal ma'am, vice principal ma'am, management, and the organizers for the great opportunity that is being given to me. Thank you, and also kindly sorry for bearing with me for the problem that has occurred.
It's okay, ma'am. So it's a time for a short break of 15 minutes. We will be continuing the session after the break. Please be online. We'll continue with the session after 15 minutes of break.
Hello. Smita. ரொம்ப டைம் எடுத்துக்கணும்டா. ஆமா. பிகாஸ் ஆக்சுவலி இட் வாஸ் 1 hour இல்லையா, அதனால நான் கரெக்டா நான் பண்ணேன்னு நினைச்சேன். ஆனா நடுவுல ஒரு இன்டரப்ஷன் வந்துருச்சு. ரொம்ப சாரிமா. பிகாஸ் ஆஃப் திஸ் பர்டிகுலர் சடன்லி இட் காட் பவர் பை ஷட் டவுன் எனக்கு. பட் ஒன்னும் ப்ராப்ளம் இல்ல. புரிஞ்சுதா கிளியரா இருந்ததா? சரிடா கண்ணா. ஓகேடா. ஓகே. ஆக்சுவலி எனக்கு நைட்ல இருந்து ஃபீவர் ஸ்டார்ட் ஆயிருக்கு. என்னன்னு தெரியல. ரொம்ப கண்ணெல்லாம் செவந்து போயிருக்கேன். ரொம்ப நான் எப்படி எடுப்பேன்னு தெரியல. எனக்கு ரொம்ப பயந்து தான் எடுத்தேன் நானு. என்னடா சடனா அப்படி ஆயிடுச்சுன்னுட்டு. மார்னிங்ல இருந்து ஒண்ணும் முடியல. ஓகேடா. ஓகே, யூ கேரி ஆன். ஓகேடா.
Start the session. Just introduce you. Now we are back from the session. After the break, we're going to start with the next participant. Now I'm going to introduce an eminent personality, Dr. Ramesh Prasad Rai, PhD, Health Science from Faculty of Science, Lincoln University College, Malaysia. With more than 35 years of experience in clinical and teaching, Sir has different certificate courses from famous universities with 17 publications in different international journals. Sir is also a former director for student affairs, and I welcome you to present your topic for this webinar, sir. Over to you, sir.
Thank you. I hope you can hear me.
Yes, sir.
Good. Thank you, Madam, for the kind introduction. And thank you also for the host. Okay, Madam Indra, Professor Indra, Principal of this Narayana College of Nursing in Nellore, and also all the management team for this wonderful conference. It was really very informative from the few sessions that I heard before this. Okay, and please accept apologies from that Professor Dato Bibi. She was supposed to present, but unfortunately she had some medical emergency. And she has actually asked me to stand in for her. And I am very grateful for that, okay, for having an opportunity to be sharing something with you. Okay, bear with me. Okay, right. So the topic today is about neglected tropical diseases in the context of COVID-19. Okay, neglected tropical diseases in the context of COVID-19. COVID-19, as we all have been hearing this morning, is a newcomer. It's not really newcomer, it's a new strain, a new mutant, would say, of the SARS, MERS viruses, family of viruses. But it has actually disrupted the life of everyone, and it's going to be remembered for a long time. Okay, so it has actually, our life has gone to a new normal. Life is not as we used to know before because of this COVID-19. For everyone in this world, except maybe like earlier speaker said, in Antarctic, you don't find this virus yet. So maybe life in Antarctic is still the same as it was before. But for the rest of the world, it's not so. So let us see how we as healthcare providers, okay, how are we going to cope in this new normal? How are we going to be, providing our services to support the healthcare of all the other conditions, disease conditions. Okay, as human beings, we are also subjected to so many other health issues. But how has COVID impacted this new scenario? Okay, so the aim of this short talk will be about how to describe how COVID-19 pandemic has impacted the neglected tropical diseases activities. Okay, explain how neglected tropical disease activities can be adapted to ensure safe implementation in the context of this new normal caused by the COVID-19 pandemic. Okay, right. So as an introduction, neglected tropical diseases are actually, what are they? They are a heterogeneous collection about 20 or more communicable and non-communicable diseases identified by WHO, and disease groups that are associated with normally poverty, okay, mainly affecting people in the tropical and subtropical countries. Okay, as the name suggests, neglected tropical diseases. Okay, in the tropics, of course, there are a lot more other diseases, but somehow these diseases have been actually largely marginalized on the sidelines. Okay, because maybe it also affects mainly people who are impoverished, okay, economically backward, and low health standards. Okay, so the NTDs are a diverse group of conditions of bacterial, viral, parasitic, fungal, and also non-communicable origin. This non-communicable origin is something interesting because non-communicable disease, especially in Malaysia, is always linked with people with sedentary lifestyle, affluent lifestyle, people who have money, people who have fame, people who have a lot of time, leisure, and they, so they get obesity and they get hypertension and they get. But why does it now come to be associated with people in the lower income group, in the poverty group? We will see why. We'll see some of the reasons why. In spite of the diversity, the NTDs, they share a common geographical and social context. Okay, the burden is predominantly located in the tropical areas across the globe. Okay, mainly affects resource poor communities where people are in the rural and urban poor. Okay, sometimes referred to as diseases of the neglected population. Okay, right. Here you can see in this pictogram here some of the most famous neglected tropical diseases. Cardiovascular disease, it's very high up there. You can see, as I mentioned just now, the non-communicable disease. So number 1, number 2 seems to be non-communicable disease. Yeah. In the dark blue is the low mortality developing countries, and the gray one is what high mortality developing countries. Mortality rate is higher here. Okay, and it's the low mortality. So it seems to be like almost equal sharing, the burden of disease. And then we have cancers, we have injuries, respiratory infections, then the infectious conditions come in here. Okay, so these are some of the examples of the neglected tropical diseases that are predominantly affecting the poor, mostly the poor and impoverished in the world today. Okay. So in the context of the COVID-19, in the present day context, okay, just to put in perspective, as of 7th of June, okay, 2021, the coronavirus cases in the world today, you can see is about 174 million. Okay, 175 million. Okay, that's climbing, and it's a new record. I think no other disease that can have. This will be the world record. It will be remembered for a long time. Okay, and death, 3 million, almost 4 million deaths. Okay, and but not all is gloom. There have also been a lot of recoveries, almost as far as the cases. Okay, 157 million people have recovered, okay, to date. So it is not something, it's not all gloom. There is light at the end of tunnel, as long as we comply, as long as there is effort taken. So this effort and this compliance actually points back to us as the healthcare providers, isn't it? So there is a way out, and we are the experts. We have the knowledge. We have the the means to guide, and it's for us to reach out to the population, okay, to let them know and to impress on the people and what is important and what needs to be done, and where it can hurt, okay, where it can where negligence can cause a lot of problems. So looking at the epidemiology of the neglected tropical diseases, the epidemiology of the NTDs are complex, okay, because they are a group of different diseases, communicable as well as non-communicable, okay, and even genetic and even injuries as well. It's complex, and often related to environmental. But one thing, the bottom line is that poverty, empowerment, okay, poverty and empowerment and low living standards, often neglect and also apathy towards health is one of the underlying factor that has made this threat a big concern. Okay, about 1.7 billion people worldwide, okay, are estimated to require at least one NTD intervention every year. This is actually more than the population of India, I think. Okay, India's population is 1.4 billion now, around there, 1.4, 1.5, I think. So every year worldwide, okay, 1.7 billion people worldwide are estimated to require at least one NTD intervention. Okay, that's a big number. Each year, more than 15 million people die from an NCD, okay, non-communicable disease, between the ages of 30 to 69 years old. This is a productive age group. This is the age group where people are in the prime of life. Okay, many of them are householders. Okay, many of them are breadwinners. Many of them are having families. Okay, and they die. Okay, 85% of these premature deaths occur in the low and middle income countries. So this actually can be seen as a vicious cycle. Okay, when the departure or premature departure of the mostly sole breadwinners or the heads of the family, the productive age group, okay, happens, then it increases the poverty. Okay, it impeaches, it makes the situation get worse. Okay, so you can see how the cycle keeps on repeating itself. 19 million disability adjusted life years on communicable diseases. See, so much of tragedy there. So how has the COVID-19 pandemic impacted the response to these NTDs? Okay, so the COVID-19 crisis has shown, because it's a new, a lesson, a new lesson for all of us. It has shown that when there is global mobilization, okay, commitment from all actors, from every sector, and a sense of crisis, medical research and innovative clinical therapeutics can move incredibly fast. I think from the news that we get from here, of course I'm not in India, India is a prime example of this statement. You see, when the Serum Institute of India, how fast it developed the vaccine and was able to, even export or even to share with other countries in such a short time. And I think it set a few records in the daily vaccination rates and all that, a lot of things. Of course, the population there is very big, and there is a lot of dynamics here with the rural and urban settings, and the population density itself is great. So we cannot expect overnight medical results, but then there is a lot of people who have been actually being given assistance. Okay, so that's a case study in itself. So it's also showing that the mix of short, medium, and long-term approaches for research and development, as well as for the containment efforts, is needed. So work is not done yet. There is still the threat is still real. There are a lot of new mutant strains cropping up. So it's not time to be relaxing yet. I think it's time to be doubling our efforts. Okay, this is the same strategy that we have followed for neglected tropical diseases, by focusing both on the repurposed drugs, okay, but also on discovering and developing new chemical entities. So the mantra is already there. Okay, I think if we were to tackle the neglected tropical diseases, the way COVID-19 has been challenged, has been confronted, I think it can be replicated if there is a will, if there is a political will. Okay, so earlier this year, from January, WHO has actually developed a roadmap for neglected tropical diseases for the next 10 years until 2030. Okay, it's a very thick document. You can read it up. Actually, it's online, easily available, and it outlines some um, very straightforward and very succinct pathways, yeah, on how we could tackle these neglected tropical diseases. And it notes, in short, neglected tropical diseases are diverse sets of 20 diseases and groups with a singular community, okay, they're poverty, impoverished communities. Okay, together they affect more than 1 billion people. And so tackling this disease does not just require medication and healthcare, also requires economic upliftment. Okay, so just to quickly show you the targets, okay, of this roadmap by WHO, 90% percentage reduction in people requiring interventions against NTDs. Okay, that is their roadmap, and 75% population, okay, reduction in disability adjusted life years are related to neglected tropical diseases. Okay, and 100 countries, absolute numbers, having eliminated at least one neglected tropical diseases. I was reading another article. It was actually from 2016. Okay, by Hotez et al. We said that in India itself has 16 out of the 20 diseases, which is very high. Okay, the incidence of this disease in India, the disease burden is very, very, very high. Okay, so if India can tackle this, if India can be this age group, will be very, very good. Okay, and number of neglected tropical disease eradicated. At least 2 of them should be eradicated. Okay, and these are some of the other the way it can be done. Integrated approaches, multi-sectorial coordination. As we saw, it's not just about giving the medication; it's also about upliftment of the living standards, the poverty eradication. Okay, universal health coverage, and also country ownership. There must be political will. Okay, as how the COVID-19 has been tackled. So this one is there. Okay, and some of the measures of the non-healthcare sectors include education, the nutrition, water sanitation and hygiene, and other relevant sectors. Okay, like economic and all that. And in the healthcare system, the leadership and governance is important. Access to essential medications and supplies, okay, financing, okay, health management information systems, okay, research and development. The workforce must be trained, properly trained, and the service delivery system must be not disrupted, must be continuous. Okay. So now let's look at some of the strategic preparedness and response plan for COVID-19 as a communicable disease, neglected communicable disease. Okay, here we see we have 6 elements, plans: suppress transmission to reduce exposure, empower communities, counter misinformation, disinformation. We will look at this one by one. Protect the vulnerable group, and also finally reduce mortality and morbidity. Okay. So what can be done to suppress transmission? Okay. In order to suppress transmission through rollout of equitable COVID-19 vaccine and vaccination, it must be given to all. Okay. In Malaysia now, the focus is on the vulnerable age group, 60 and above, and also to frontliners first, and then the high age group. But now there is growing evidence to show that even children are vulnerable. So there is talk about vaccinating people as young as 12 years old. Okay, so plans are being drawn up in the country. I'm sure something similar must be happening in India as well. Okay, so the implementation of recorded, effective, and evidence-based public health and social measures and intervention, prevention, and control measures, including detecting and testing of suspecting cases. Okay, and also the investigating clusters of cases. Okay, tracing the contacts, supported quarantine of contacts, isolating probable and confined cases. And lastly, implementing measures to protect high-risk groups. Okay, who are these high-risk groups? People in the upper age group, and also people living in high-density population areas, people in contact, frontliners. Okay, these are actually some of the most vulnerable. And also not forgetting the ignorance. There's a lot of ignorance. There's a lot of misinformation. There's a lot of myths, okay, going around. So as healthcare providers, as people who are empowered with information, it is our duty to convince, to be a role model, as well as to convince the people on the right information. Okay. Number two, reduce exposure. Okay, reduce exposure by enabling communities to adopt risk-reducing behaviors and practice infection prevention and control, including avoiding crowds and maintaining physical distance from each other. Okay, practicing proper hand hygiene to at appropriate times, and correct and rational use of masks and improving ventilation. Okay, indoor ventilation. So this is something that it's surprising to see that sometimes even healthcare staff are violating some of these basic safety measures. Okay, what more the general public? I mean, like injuries or smoking or even like cholesterol and all that, it's so obvious. Virus is something which is so abstract, cannot be seen. So the people on the street, some people, they think that it is actually a scaring effort, a political tool to control people. Okay, people have all sorts of abstract imagination on what could be alternative realities. Okay, so it is sometimes very sad to see that these things are happening. Okay, empowering communities. Okay, empower communities to lead or to be part of the response decision-making process by reinforcing risk communication and community engagement approaches that can reinforce local solutions. Okay, increasing the trust and the social cohesion, and ultimately a reduction in the negative impacts of COVID-19. In empowering communities, we can see that I can only speak for Malaysia now. Okay, now even the mosques and even the temples and the social influencers, celebrities are coming out. Okay, they are actually speaking for. Okay, they are actually leading the psychological or the communication effort, so that the general public has more complying with the safety aspects. Okay, now even vaccination centers are being opened up in the shopping complexes, in the shopping malls, and drive-through. I'm sure even the US and India will be similar. Okay, so barriers are being broken down now. Okay, countering misinformation and disinformation. Okay, counter misinformation, disinformation by managing the infodemic. Okay, communicating with and engaging and empowering communities. Okay, while also enriching the information ecosystem, online and offline, through relevant, actionable, and localized guidance that communicating risk and signs for the specific target population as required. Okay, here, of course, it is very sad that there are still people out there who perhaps for fear of losing their influence or their circle of influence, they like to sensationalize myths and alternative realities. So I think for us as scientific workers, it's important to counter this misinformation with empirical information, facts and figures. Okay, facts and figures. Using effective use of the social media. Okay, it is very important. And we have to win the war. Otherwise, if we are complacent, everybody will become the victim. Okay, everybody will become the victim because the virus is going to stay mutate and it's going to be out for everyone. Huh? Okay, protecting the vulnerable through vaccination. Okay, protect the vulnerable through effective vaccination, ensuring vaccine deployment readiness in all countries and all population by communicating, implementing, and monitoring the COVID-19 vaccination campaigns and by engaging healthcare workers. So the aim here is to vaccinate at least 70 to 80% of the population so that there is herd immunity. Okay. Building vaccine acceptance and demand based on priority groups, taking into account gender and equity perspectives to leave no one behind. Okay, right. Next, lastly, to reduce mortality and morbidity from all causes, reducing this mortality and morbidity from all causes by ensuring patients with COVID-19 are diagnosed early and given quality care and treated in a COVID-19 special care pathway with access to corticosteroid and whatever is necessary. I'm sure now there are a lot of drugs, Immercitin, and then even remdesivir. There are a lot of medications that are being tried out. Okay, the jury is still out there. I think whatever is happening, probably when later on when the data is collected, more information is collected, there will be a clearer picture on what works and what actually is not really working. Okay, health systems must surge to maintain health for all causes. So you see, the strategies that we have presented, these are the strategies being used to combat COVID-19. Okay, so these are some of the lessons learned that could also be applied to NTD programs. Okay, if the fervor, if the will is there, okay, the population is the asset of the country. Since my audience is India, India is known for a young population, for vibrant population. You're very innovative, you're very eager to improve and all that. So we don't want to have a population which is sick from the onset, which is not fit to participate in at the cutting edge, at the forefront. So WHO issues interim guidelines and implementation of NTD programs, community-based healthcare, community-based healthcare including outreach and campaigns in the context of COVID-19 pandemic, interim guidelines, and consideration for implementation mass treatment, active case finding, and population-based surveys for neglected tropical diseases in the context of COVID-19 pandemic. Okay. So you can see that similarly to COVID-19, which is actually a very new health threat, the neglected tropical diseases are something which has been there for us for quite a long time. It's already become chronic. It's already become an endemic in certain places. So with this new fervor, maybe as the name suggests, neglected. Okay, maybe there's not much glamour in it. People are already like tired of it. Okay, or there's no much glamour in it. So, but with this new fervor to get healthy, to empower one's own self, that our health actually is our responsibility. Every person's responsibility. It's not the responsibility of the government or the hospital to make sure that we are healthy. So with this COVID-19 type of campaign going on, I think the same aggressive fervor must be renewed for the NTDs as well. Okay, so that the roadmap, WHO roadmap, could be achieved. Facility-based healthcare, maintaining essential health services. Operational guidelines for COVID-19 context, interim guidelines. Okay. So next, let us look at maintaining essential health services, operational guideline for the COVID-19 context. So what can be done? Adjust governance and coordination mechanisms to support timely action. Okay. Actually, this morning I was just on the WhatsApp group. One of my friends sent me a new initiative between the US and India by a group in India. Actually, the Madan, it's on Madan app, which actually can locate which are the hospitals which have ICU beds available and oxygen and all those supportive action that is available. Okay, because in this COVID-19 era, at the height of this outbreak, there was a lot of panic. Not enough oxygen concentrators, not enough ICU beds, not enough healthcare personnel, even vaccines was not enough, everything not enough. Okay, there was a lot of panic, and people were going everywhere and hysterical, and there was a lot of even violence and also things happening. So this is something very innovative, something very good that you can come up with information online, on time, real-time information. Okay, so this is a very good example of that. Okay, prioritizing essential health services and adapt to changing contexts and needs. Optimizing service delivery settings and platforms. Okay, and establishing safe and effective patient flow at all levels. Here, of course, I think it's not just the duty of the healthcare personnel. I think the other agencies, the enforcement agencies, they have to work hand in hand. The police and also other enforcement agencies, make sure there's no profiteering. Okay, and there is safety of the healthcare personnel. I tell you, the healthcare personnel are the real heroes. Some of them are really working back-breaking hours and selfless service. Okay, so that screening, triage, and targeted referral can be done. Rapidly optimize health workforce capacity, maintaining the availability of essential medications, equipment, and supplies, funding public health, and to remove financial barriers to access, strengthening communication strategies to support the appropriate use of essential services, and use digital platforms, okay, to support essential service delivery. As I was mentioning just now, the innovative new app design. Okay. So what is the way forward? Okay. Countries around the world are facing the challenge of increased demand for care of people with COVID-19. Hospitals are crowded, the resources are stretched to maximum, okay, compounded by fear, misinformation, and limitations on movement that disrupt the delivery of healthcare for all conditions. So, of course, there is a lot of chaos, but it doesn't mean there must be breakdown. Rationality must prevail. Okay, we actually, I think for the healthcare personnel, we have to find renewed vigor, renewed strength, renewed courage to thrive under chaos. Okay? Under all the chaos, we must remain calm, and we are continue doing our God-given service to mankind. It is recommended that practical action that countries can take at national, sub-regional, and local levels, reorganize and safety maintain access to high quality, essential health services in the pandemic context. Well, Lincoln University College is moving. We are in the middle of this in Malaysia. We do a lot of research and we collaborate a lot, okay, with the World Health Organization to curtail the increasing incidence of neglected tropical diseases in the context of communicable disease, okay, COVID-19. So Lincoln University College of Allied Health Science Programs provide the knowledge and skills in the resolution and management of the neglected tropical disease in this context. And in conclusion, neglected tropical disease in the context of COVID-19 it is important for us to remember that though it is neglected, okay, these diseases can kill. It's important for us to remember they do kill, they do disfigure, they cause a lot of stigmatization or debilitate millions of people every year, often the poorest of the poor. Okay, remember the age group, 35 to 60 age group. Okay, these are people who are in the most productive time of their lives. Okay, they bring financial devastation to affected families, feeding a vicious cycle of poverty. Okay, out of 1.7 billion who are affected, more than half of them are children. Affected, not just affected by the disease, but affected by the people who are being affected by the disease, by the patients. After the patients leave, their families are, impoverished. Okay, the global community must not forget neglected tropical diseases. Even with COVID-19 occupying all our efforts now. Okay, climate change will certainly make things worse, as some climate-sensitive NCDs will likely spread. We have a moral perspective to end the neglect of people affected by entities, and it is very important for all of us to act collectively and act now, not postpone the thing. Thank you very much. That's all I have to say. And these are my references. Thank you. Any questions?
Excellent presentation on neglected tropical diseases in the context of COVID-19. To panelists, if you have any questions, you can type in the chat box.
Yeah.
Participants, you can type in the chat box.
So if there are any questions, you can write in the chat box. Okay, you have some hands raised. Professor Indra, you have a question, ma'am? No questions, I think, huh?
No. Yes.
So can I stop sharing now?
Yes, thank you.
Thank you, Dr. Smita. Thank you for the...
Thank you very much, sir.
Yeah.
Now let me introduce the next speaker, Professor V. Jayanti ma'am, Principal, Sri Narayana Nursing College. To introduce about Madam, she has 35 years of state government service as a staff nurse and senior staff nurse and ward manager, worked in all areas in OBG, including operation room, and held various positions as academician at school, college level, served abroad Ireland more than 5 years as preceptor, senior staff midwife, clinical midwife manager, and she is a reviewer for different journal boards and active at different research activities. We welcome to present your topic on the day, ma'am. Over to Jayanti, ma'am. Can you hear me, ma'am?
Yes, just give me a minute.
Yes.
Good afternoon to everyone. Thank you, Usha, for giving me a little bit, what to say, like short and sweet intro on me. Thank you very much. And I'm so privileged to be a part of this fourth international conference. First of all, I would like to thank our management and also our Dean, Madam Dr. Indra, who had been the catalyst. She is always the catalyst for bringing out the creativity or the whatever may be the area, whomever is looking for anything for innovation and improvement, which could bring changes in our nursing profession. You can take her as a role model who has always had some inquisitive in her mind, looking for more. That is the reason behind why we are here today in organizing such a need felt hour of this international conference on this the burning issue, which is covering not only our India, entire world is still under. We are in the second wave, almost in maybe the pandemic itself is taking another version. Like that's what we are. Again, we are in preparedness, getting ready for to face even the so-called third wave. Nobody is clear on which nobody is clear. And once again, I thank our Madam Dr. Indra for giving me this opportunity to be a part of this knowledgeful session. And before I could start my session, I would like to mention a few important things before. Otherwise, the session won't be it's like continuous one, because the session organized in such a manner that one after the other, like not only it comes as a sequelae for post-COVID occurrence, it comes like as it is for even for the presentation. So beautifully, very well arranged. So I thank Dr. Valli, the present Deputy Director of Medical Nursing, who has appreciated the theme very well. Like, this corona doesn't leave anybody because you are young and you are old, isn't it? So but you can say children are, no, yeah, still children are being also affected. And she has appreciated the theme, and she also in her unveiling the theme, she beautifully mentioned in a nutshell, starting from how the children are affected, how the elderly affected, what are all the system affected, and what way the nurses can take control over it. Like that was really interesting. And she also insisted that the slogan, SMS, we have to follow throughout. I don't know how many years we have to follow, though the so-called developed country like America says now this is the time. 2 doses of vaccination is enough. Now you can come out from mask. But we are still worried. I saw a child waiting in the airport. I saw one in YouTube. The child, maybe around 1 or 2 years, the mask was there on the face, and the mother wants to remove the mask. Child started crying. Then immediately when the mask was put, the child was happy and quiet. Look at the situation the children are being exposed, and how they are living in that era of this so-called killer disease or the pandemic. And when keynote was given by our Madam Indra, as usual, she always gives something new for us to have some idea. Here I have got something to take, not necessarily a message which is always given at the end of the session. She gives from the time she starts till she finishes, she'll give information. Whatever she gives, that will be more relevant, and looking forward, something there left for us to keep in our mind to follow through. Thank you, Madam, for this wonderful keynote address. And Dr. Vasanta Kumari. Before I go into Dr. Vasanta Kumari's beautiful presentation, I would like to thank the entire crew of our Narayana College of Nursing, the big ship, which has got not only one, the person, the captain of the ship. Everyone is treated as a captain in the ship, because everyone is being given privilege to think according to the way they conceive in their mind. Then the shape will be given finally by the people. That is only sharing of our knowledge we do. Constantly we do. That's what where we are today. That's, and we are at this prestigious juncture, I would like to say that we are 11 in numbers, PhD students in our college under our Madam Dr. Indra. Though we are doing our study in various universities, all reputed universities, irrespective of the year of study, even from the first year, you will be thrown into like child thrown into a swimming pool, just somewhere you have to try and come out. That's what the status. But finally we will be gained with some knowledge, some input which will be helping you throughout your career. So the beautiful crew, all these junior and senior captains I pat you on your back, giving you always like a positive applause, and keep up the good work throughout your study. Not only you are stay in Narayana, wherever you go, you have to show your this proven enthusiasm throughout your career. That's what I would like to say. And Dr. Rasanta Kumari, when she said, like, she gave a beautiful, though we have information spread all over we have information every now and then, because this is not stopped in one single incident. It is there since, as Madam gave you clear, with all this first eruption and noted cases starting from December 2019, and her presentation was excellent in such a way. Yes, this is the way it is started. This is going to be there, and how we can cope up. A very, very important, and beautifully it was given with the beautiful examples. And thank you, Dr. Rasanta Kumari, Madam, for being the expert panel once again on behalf of our crew. Thank you, Dr. Rasanta Kumari. I hope to see you in some other sessions also. Thank you, Madam. When I come to Dr. Ramesh Prasad from Malaysia. Very good afternoon, sir. And we are so happy that immediately after the epidemiological stages, and we got the information, don't worry, because with this we can manage. So everywhere we are here like warriors. Always we are warriors, not only in nursing area, we also have been a warriors for anything and everything. It is just a tip of the iceberg where our capability is being brought out to the entire universe. But we are always ready to take up whatever information given positively, and we are quick graspers. That is the big quality we have as nurses. We do have that grasping. That is maybe one extra quality. I don't know whether, as I always say, it is not a innate power we get. That is, we do develop. We do have to strive through to get that kind of capacity. You have to continue, maintain or keep up the potentiality throughout your career. That's what we expect. Thank you very much, sir. And yes, sir. Yes. We promise as frontline warriors, though the frontline health workers, we do being named. It starts with the doctors. And I'm much privileged to say, though the doctors are there, this 24 into 7 into 365 days, in all 4 shifts, if needed, all 24 hours, we are with the patients. We do care on or off the settings. Whether you are on duty or not on duty, you do your work. That's what I always feel that. And yes, sir, you said that WHO target, you said maintaining essential health services, the target which is spread over for 10 years. Yes, with that information we latest information, like by integrating the approaches and multi-sectoral coordinators and universal health coverage, and finally country's ownership. Yes, that's what, when you appreciated our country, India, I'm feeling so proud that you said we so much of vaccination being produced. And with that, I have to tell now, yes, sir, we do have to tell, even in our population also, almost, it's not even covered 50% of the population, which is expected to be covered with the vaccination. Here again, we as Bharat belong to a country which has always been feeling happy in sharing, like whatever you get, don't keep too much for yourself. So you keep on sharing, then automatically you will be having your own share. That's what the principle we do adapt. Hopefully we'll be having enough supplies or to have this vaccination covered for irrespective, not only for our own, this as you segregated, like high risk people with a comorbid condition, and with the prediction of the third wave, hopefully we would like to have the 100% coverage vaccinated in our India also. So thank you very much, sir. Appreciating here and there, and thank you, sir, for sharing that ideas. So before I start my own session, and I always say, like, I'm functioning in a role of educator right now, but basically every one of us are a nurse. That we should never forget, we'll never forget. So with that, I would like to start my session. My given topic is role of nurse-led clinic in post-COVID sequel. So my session, how I have, it's again compartmentalized in 4 aspects. One, I'm not going to talk anything in detail because we have got enough input on COVID and the epidemiological and neglected tropic diseases. Again, you have to be a bit careful also. My coverage will be on challenges right now as nurses, how you come across, and ethical principles and code, which is having the control of our own professional functioning. And third aspect, as it is, what is post-COVID sequelae, which affects the entire system from womb to tomb. And the last one will be the role of nurse-led clinic, though this so-called nurse-led clinics are not that much prevailed in our own country. Not necessarily you have to work in a separate setup clinic. You can work, you can share, you can even have a function wherever you are working. You can, with your permitted scope, you can function as a nurse to do your services. That's what I mean to say through my presentation. And a little bit of planning is there at the end of it. Kindly bear with that if I'm not giving much of our situation, though our central government has planned roughly about 150,000 of nurse-led mid-level healthcare providers in the rural setup. It is started from 2019. Hopefully by the end of this, maybe this current pandemic situation also will be paving the way to have more and more in numbers, so that with our autonomous status and our own, as I told you, with the special nature of our own potentiality, we may follow this kind of expectation from our own nursing fraternity. With that, I'm ready to start my session. Thank you for patient listening before my actual session. So I will share my. Is it okay, Smita? Shall I start now?
Yes, ma'am. Yes, ma'am.
Thank you, Usha. Thank you.
Yes.
Okay. So, a small introduction, it goes like this. The rapid spread of COVID-19 poses a serious threat to human health and is impacting severely on public health, global communication, and economic system worldwide. This is, yeah, everyone is facing this difficulty, and nurses are the key members of healthcare team charged to control, prevent the spread of infection, diseases. Moreover, nurses work on the front line providing care to individuals infected with COVID-19. So the lived experiences, strategies, and policies related to confronting, exploring, and managing COVID-19 are important to healthcare professionals and nurses in preventing and managing future outbreaks of infectious disease. That's what we do have sessions, webinars like this. So no area should be left neglected or forgotten. So in that manner, first of all, we have to protect ourselves, and we have to have more information on how to do, how to carry out in your day-to-day practice, how to take care of yourself and also the clients whom you are looking after, and like with the family members and the society at the end. So the immediate efforts to control and prevent COVID-19 and care for those who are infected remain ongoing. Yes, because we are learning. Last century, we had some information, like last century also we had one pandemic like this. But when I saw those pictures, through somebody's sharing, even those days, they were like, the so-called the developed countries, they were instructed or insisted to having to wear masks. So still that is continuing. So like that, the information what we get, it is not like, it is not going to stop it with one point where you say, yeah, you can stop with this. Important areas like having a mask throughout your stay, wherever you go out, and maintaining the distance. Yes, I think this has to be there for at least quite a number of years to completely come out from the scenario. And COVID-19 pandemic, the challenges to the professional identity of nurses, impacted the nurses and the field of nursing profoundly in terms of direct care capabilities, nurse practice issues, and healthcare system operations. Because we are the primary human factors affecting care outcomes. We are giving care to the clients, and we are also the major part of our healthcare system importantly, the pandemic has influenced strongly the professional identity of nurses, nursing education, as well as the focus of nursing research. So we always we always been feel wounded sometimes when you are projected in the media. At times, majority of the times, we are always been projected. Nobody will be appreciating, like even if you take some, I don't know whether I can share that in a kind of that viral thing which is happening, like, the memes. So they were also like, no part is left without any, there used to be, any, like, decency may not be there when it comes to projection of nursing roles. So that is changed completely upside down, because the situation has warranted them. Look here, if you do like this, if these people are not around, your life is at risk that they have witnessed. That's what the people are started, at least not necessarily they should saying thanks, thanks, thanks at every moment, at least not criticizing the people who do some for the humankind. Professional identity is a critical issue for nurses of its close association with issues such as nursing roles, responsibilities, values, and ethical standards which are unique to the nursing profession. Yeah, we do have our own restrictions and we have our code of ethics. We have our ethics principles because we are not dealing all the time with the inanimate things. We always are mingling, or we always with the crowd where there is life. So, however, during the COVID-19 pandemic, in addition to facing regularly high levels of physical and emotional stress, clinical nurses suffer regularly from moral distress because of conflicts rooted in complex ethical issues related to their professional practice, high level of acuity, patient death, and long working hours. You may think why I've brought everything in one simple paragraph, because every other bits and pieces of the nursing and nursing profession, personal life and professional life been affected because of this pandemic. So a high number of frontline nurses were infected during the SARS-CoV-19 epidemic in 2020 and 21, and as a result experienced extended separation from their loved ones and or died in the line of duty. And this year particularly, here in our own Tamil Nadu state, we have lost many number of nurses, sudden deaths, very young age, suddenly because of this pandemic. This year it was so painful to see even one of our close friends and colleague has been suddenly lost without even, she realized he lost his life. We don't even have time to mourn for whom we are mourning. So situation is very bad, and we don't have any time to even think whether it is your own family, the losses for your own family, or for your friends at the circle like that. So really it has affected every aspect of our nursing life. Exploring the psychological distress and social burdens experienced by healthcare professionals and nurses during this outbreak will be vital as well. That is the reason we do have our session. Why? How we can, you cannot modify every aspect, because this is not coming, which is we are facing is not a planned one, which you can predict. Oh, this will be the happening tomorrow, like that. Every other second becomes as every other minute has become a climax section of a movie. So you cannot predict. You have to keep your fingers crossed what way you are going to be affected, what your routine is going to be affected. So you have to be like in a panicky situation. That is the scenario prevailing among our entire country, particularly the profession like nursing. So nurses, ethics, and the response to the COVID-19 pandemic. So when I said the situation where we are living now, and along with that, how this ethics and the responses to the COVID pandemic, we do have to be obliging, or we have to be within the framework formed or controlling, or maybe regularizing our day-to-day functioning. We do have to remember this aspect. Professional nurses historically bring compassionate, competent care to disaster response, but are challenging to provide care when the nature of the work puts them at increased risk. When we talk about this, definitely I have to tell about our pioneer of modern nursing, Mrs. Florence Nightingale. When she has started her nursing, she herself was not a nurse. She was from a royal family, noble family. So she started serving, after the Crimean War, like where the soldiers were wounded. That was the starting period where the nursing started without, nobody was asking whether, nobody was debating whether your nursing is a profession or occupation. Then we had to wait for so many years, almost for half a decade, to prove, yes, ours also profession, but with life, with passion to take up nursing. We have to prove. After proving that also, we are facing situation like this where our proving ourselves, it continues to be it is ever ending. But with that, every difficulty you come across also, you take up that as a reward for to just groom yourself, or you just to modify yourself, or to come out from, irrespective of number of obstacles you come across in your day-to-day life. So key challenges faced by nursing professionals during the COVID-19 pandemic include preventing staffing shortage and providing psychological social support to nurses. This is very important because now the generation, this shortage of nurses, how we are getting? Everybody is human being, everybody, if the girl is a nurse, is from, she is an unmarried girl, definitely the parents are not letting her go and do duty in the wards. If she is married, family members are really afraid to send them for work to serve the patients who are affected with this corona. Naturally, because if they lose their wife or sisters or mothers, who will be there for them to be to take care of them? Here, though the nurse herself is willing to serve, there are other parameters. There are some areas where she has to cope or balance. There also, then it becomes shortage of in staffing. Again, that is also directly proportionate. When the staffs are reduced in the actual clinical setup or where the need is felt, automatically the loss will be more. And once the nurses have started working with the shortage and other thing, the psychological and social support we have to provide to the nurses, that numbers or in the issues or the range becomes enormous. And nurses struggle with feeling physically unsafe in the response situation, such as in times of scarce resources, where supplies of such items as personal protective equipment may be inadequate. This is one example when they are working in the actual setup. But when I had my first dose of vaccination in a primary health center, I was witnessing a scenario like how a nurse was targeted by multiple stimuli. I can give you this as an example. I was like, we were being given tokens to wait. My token number was 22, where the token which was going on was token number 4. So we were all everybody was waiting patiently in the queue. But all of a sudden, one person came and he was asking one information which was totally irrelevant. He was literally speaking, distracting the nurse or preventing the nurse from doing her job of giving vaccination. He was asking some uh, information which is not going to help him also. But he was so stubborn and he didn't leave the nurse to continue her job. And by the time, it was only the token number 6 was there for waiting to get his slip to go into where the injection was given. So that fellow didn't leave the place. And one more person came and he said he didn't get any information saying that for his second dose, he didn't get proper WhatsApp message saying that when do I come? And she said, this is not the time. You have to come in the afternoon hours where I can finish giving these people who are already in the list. He didn't leave her. And third stimulus was the doctor who called her was like, no, who called her inside and he was asking some immediate procedures to be carried out where there was short staff, so she has to go there also. And fourth thing, the thing happened was like the person already had 2 doses of vaccination. He wanted to get the information like how to download that final vaccination done list. Imagine her situation, how she can, after all, my token number was only 22 and she has to give almost for 100 doses. see that situation, like, that is, there she was imposed, like, she was in a situation because these one or two people started fighting her. She was almost in a status where maybe some abuse could have happened to her. Anyway, with my thing, no, I didn't, because I was not standing, saying her like I was a nurse. I just went and I said, please, everybody, please see that this, I was just helping her in sorting out. I could not continue, for a long time. Luckily, other people joined me, gave hand in sorting out the issues. This is the situation. People, whether they are over enthusiastic or maybe no enthusiasm at all, that is the status where we are in a situation like we are facing every day, day-to-day life. And nurses are concerned about professional, ethical, and legal protection when asked to provide care in such high-risk situations. Organizations providing positive social support to nurses may help promote their professional identity. That's what we want to get, some identity achieved through our functioning, not as a simple label saying that you are as a nurse. Here, the Code of Ethics for Nurses with Interpretive Statements 2015 provides guidance for nurses in situation of crisis, such as responding to pandemics during pandemics. Nurses must decide how much high quality care they can provide to others while also taking care of themselves and their loved ones. There may be times when a registered nurse must make a choice based on moral grounds in order to maintain professional integrity. The effective communication, that's what, that will give almost like, effective communication is the vital role where every nurse has to develop, which will give the apt result. You can see that there shouldn't be any like misleading or misleading information. You have to be clear when you are communicating or when you are taking some instructions to carry over. So very, very important. And organizational management regarding a nurse's ability to provide care to patients is essential and must be heard and valued at all organizational levels. That's what lacking, and it has a long way to go. Hopefully that area also will be like, we'll get positive environment, thereby we can function with our own ability. The registered nurse is responsible for being knowledgeable about state law under which they practice during a pandemic. So that is also very important. So in considering the nursing profession's duty to society, Interpretive Statement 8.4 of the Code of Ethics for Nurses with Interpretive Statements states all actions and omissions risk unintended consequences with implications for human rights. Thus, nurses must engage in discernment, carefully assessing their intentions, reflectively weighing all possible options and rationales, and formulating a clear moral justification for their action. Definitely, we will be gaining that status with all this, our gained ideas and our own decision-making capacity, and with some amount of privileges given by the people under whom we are working, and also with our autonomous practice. Only under extreme and exceptional conditions, while conforming to international standards and engaging in an appropriate and transparent process of authorization, may nurses subordinate human rights concern to other considerations. Nurses must continue to advocate for systems and protocols that protect their ethical obligations as nurses, as well as ensure equity and fairness to all concerned in times of pandemics. Multi-speciality nursing teams are responsible for managing critical care environments and improving screening, diagnosis, treatment, and education about ever-changing patient care models during the COVID-19 pandemic, on which topic only I'm going to talk a little bit exposure at the end of before my end of my session. And COVID-19 has changed not only the way that we educate and enhance the professional development of our nursing staff, but also the necessity of conducting researches. Thereby, we can improve our standards. Thereby, we can develop our own protection. Thereby, our day-to-day practice becomes a routine one. So now I've come to an actual topic of mine, which is post-COVID sequelae. I'm going to cover quickly because I've given the entire picture of what is post-COVID sequelae. affecting almost all the systems of human. As with WHO, generally people will take an incubation period of 10 to 14 days to recover fully and sometimes more. Sometimes here can remain for more than 20 days to up to 45 days. Due to long-term effect of coronavirus, patients can develop post-COVID complications. Severe acute respiratory syndrome, coronavirus SARS-CoV-2 can damage the lungs, brain, blood vessels, skin, nerves, kidney and heart, which increases the risk of long-term health issues. However, the virus may remain in the body up to 3 months after diagnosis. Because as the disease will have its impact or the sequelae for a long time, as nurses working in the acute setup or community setup or having your own individual practice like clinics where you can continue monitoring these patients or the clients whomever you are taking care of. So some people get a second positive test result even after they recover, although this does not necessarily indicate the virus is still transmissible. That is the valid information just for us to remember, because even after taking vaccination, for example, we can say like, the vaccination, the duration between first and second dose, Covaxin and Covishield and Sputnik, like so many things we are getting day to day because of the constant research is carried out. We are getting every day some newer information. But what we have to remember is vaccination definitely gives protection against this pandemic situation, that is COVID situation. That basic principle, basic truth is there. So definitely when getting opportunity, we should not hesitate to take up the vaccination, apart from the exemptions where the doctors advise not to take vaccine at the moment. Like that, unless otherwise, if anybody is getting chances, you have to get the vaccination, both the doses. Post-COVID syndrome. In simple complication, it becomes a syndrome. Syndrome is a symptom complex. We always say any syndrome is a symptom complex where you get two or more complications. A broad range of new ongoing or returning health conditions. People can experience more than 28 days, 4 weeks after first being infected with the coronavirus. Even asymptomatic people who did not have symptoms when they were infected can have post-COVID complications. These complications can have different types and combinations of health problems for different length of times, who are at the risk of post-COVID complications and can have long-term effects. Elderly old age group people and people having serious medical conditions such as diabetes, immunodeficiency disorders, cancer or chronic diseases are at the risk of developing post-COVID complication. We simply say with the comorbid conditions. So like any elderly people themselves is at high risk with comorbid conditions or high risk for post-COVID complication. As per recent data, even young people feeling healthy post-COVID recovery can also have long-term effects of coronavirus, may experience symptoms for weeks to months after infection. We have to be very, very careful in the second wave when like what we are currently facing, younger generation losing their life, more younger people from younger generation, all of a sudden. You see, I didn't have any symptoms. Suddenly, they have symptoms for 1 or 2 days with severe oxygen deficiency, and they go with the low oxygen sats, and they suddenly the death occurs for the week. We are getting information like sudden deaths from the younger age group also. That is also a bit like warning sign where we have to be careful. And causes of post-COVID syndrome. Possible long COVID causes identified in COVID recovered patients may include reduced or lack of response from the immune system, reinfection of the virus, multisystem inflammatory syndrome, prolonged hospitalization due to severity, post-traumatic stress. These are some causes where people are susceptible or prone to get post-COVID complications. As per the recent data, 30 to 40% of who had secondary infections, survivors of acute COVID-19, may be at increased risk of infection with a bacterial, fungal infection or other complication like mucormycosis, how that is started erupting now in our own state, and like the condition, if it is diagnosed earlier, treatable. That's what the report says. So again, that is one best example for one of the post-COVID complication. However, the secondary infections do not explain the persistent and prolonged consequences of a previous infection in post-acute COVID. Post-COVID long-term symptoms and complications. So this is overall symptoms. So which is I have just given for us to have just awareness, because we know we so whatever information we get, yes, this I know, yes, even if small WhatsApp message, yes, this message I know, yeah. Like just for us to just have a revision, I've given this as long-term symptoms and complications in a quick way. We can just go through this. It starts from body pain, joint pain or headache, high blood sugar, fever, feeling of tiredness or lack of energy, loss of taste or smell, shortness of breath or difficulty breathing, coughing or chest pain. These are the symptoms we see people who are saying that, who are become panicky. We'll say, we should not use the word, sorry, I should not have used that, because these are the predominating symptoms. Once they have continuously, they have to go and have the checkup for whether they are positive or negative. And inability to focus or difficulty thinking or a lack of mental clarity, a rapid or false heartbeat, anxiety disorders or depression, dizziness or lightheaded when you stand up from sitting or lying down, orthostatic hypotension, red bumps or rash on a flat red patch of skin, symptoms that get worse after mental or physical activities. Post-acute COVID-19 syndrome defined if people affected with COVID, after recovery, they are experiencing other severe symptoms apart from other normal or regular defined symptoms may include myocardial infarction, these symptoms are more severe in nature, chest discomfort with or without dyspnea, nausea and diaphoresis, deep vein thrombosis, neurological symptoms, gastrointestinal symptoms like loss of appetite, nausea, vomiting, diarrhea, and abdominal pain or discomfort. See, affecting almost all the areas, all the system. Pancreatitis, hemothorax, collection of blood, these are there for post complications in a long run, or maybe the syndrome, it's happening in a symptom complex. So pneumothorax, pulmonary fibrosis, arthritis, fungal infection. So long-term organ damage. So once the symptoms are continuing, it is there for long period, then it damages the organs ultimately, which ends up in multi-organ dysfunction. So conditions associated with the long COVID-19 may be the result of injury to multiple organs, including lungs, the vital organs like lungs, brain, blood vessels, skin, nerves, kidney, and heart. This can be seen as metabolic, musculoskeletal, cardiovascular, and neurological complications secondary to the disease. Organ damage may increase the risk of long-term health issues. As per recent data, mainly affect these organs and body parts. As I told you, almost all the vital organs will be affected. Lungs, heart, may also increases the risk of developing Alzheimer's disease and Parkinson's disease. Brain, here there are many reports where young people with COVID-19 also experience neurological symptoms include muscle weakness, tingling or numbness in the hands and feet, and can eventually cause paralysis. Guillain-Barré syndrome. And kidney, sudden loss of kidney function known as acute kidney injury. Dialysis may be necessary in severe cases, but this type of kidney damage can sometimes be reversed. People with a CKD are higher risk of developing a severe symptom post-COVID recovery. I am not threatening, and when I got information, the resources, I was literally I was wondering what exactly is going to happen. We cannot say every other person who is affected or had stage 1 or stage 2 of this COVID because it says totally uncertainty is there. Who will get complication? Who will have, and in long run will be having multi-organ system failure? See, just see all these things are possible. Maybe the future researchers will give some answers like, okay, how we have to bring down all this from multi-organ failure to just narrowing down, or get some solutions or some treatment aspect. Thereby, these complications can be totally prevented. I don't think it is possible within a year or two. Definitely, we are with this vaccination with a less period, like not even just a year period, we got some vaccination against this killer, this pandemic, this corona. Definitely, scientists are working hard to get for recovery or to get solution for all these kind of issues, even for this symptoms which are going to impact in a severe manner. So we have to be very, very careful. Like if someone is complaining, like no, we have to say like this is the only normal. We have to have we have to think in such a manner, like if anyone who comes to you for any opinion or some suggestion or in asking, you cannot say like, no, this is maybe, like you are in a position, you say like this is a simple cold, maybe it will go in a day or two. Like we have to be very careful when you say some advices, like because see the impact of this COVID and warning signs of post-COVID recovery. Some of the people may experience symptoms such as reappearance of fever, chest pain. This is what the WHO definition says, starting from 7 days to 28 days. And diagnosis of post-COVID syndrome, if someone experiencing any symptom necessarily require to check again the positive results, need not check, because the physician may require the complete medical history and previous COVID treatment. Apart from checking this, regular vital checking like temperature, blood pressure, pulse, and SpO2 level and breathing function, physician may require the test. I have given a set of test parameters which you can get. The doctor may ask you with the symptoms, this with all this regular checkup history. This is, he may ask for serum electrolytes, not necessarily everybody who comes with the symptoms. Depends upon the physician who examines, may need these areas for your exam to diagnose. Serum electrolytes, kidney function test, liver function test, C-reactive protein, troponin test, D-dimers, serum ferritin, ECG, complete urine examination. And these are some warning signs of post-COVID recovery. I think Dr. Valli Madam also has given this small gist of this, what will be the post-COVID signs of post-COVID recovery. That is continuous shortness of breath, reappearance of fever, dizziness or lightheadedness, persistent chest pain, feeling of tiredness, and muscles or joint pain. You can just, I'm just recapping it with, these are the symptoms, may be the sign of post-COVID complication. So coming to my more relevant area, more not relevant, happy to be giving this exposure on nurse-led clinic, because my PhD topic also, I've taken the importance or the role performance of nurses in a separate individual run clinics. So I'm once again happy to take up this topic, because I'm feeling so happy, proud to practice as a nurse practitioner, nurse specialist, whatever may be the position you have. But ultimate thing is providing service to the human. So in a nurse-led clinic, the nurse has his or her own whole patient caseload. The service often involves an increase in the autonomous functioning of the nursing role. The nurse-led clinic requires the patient to come in a rigid time slot, to break up the rigid time slot, where normally when the patient looks for a doctor's visit, he has to go, he has to fix up the appointment. You have to have lenient timing to be with the patient, like no, that is maybe possible in a nurse-led clinic. There is the ability to admit and discharge patients. I've given some criteria which is practiced in certain clinics in abroad. And I don't think that much of advantage we do have in our own clinics. We do have some clinics nurses are practicing independently, particularly in the midwifery area, but we do have to go a long way to have such autonomous functioning. Why develop a nurse-led service or clinic? Increased patient access to appropriate healthcare personnel. Where in a nurse-led clinic, you will have your own patient load and you can sort out whom you have to give referral, whom you can treat them, whom you need some triaging services, or where you can function of your expanded roles. Like as nurses, we are always function in extended and expanded roles. All that role functioning you can follow, you can put it in your practice. That much of freedom you have your own clinic. And psychological support. So whomever you treat, whomever coming to the clinic need not be a patient, because we cater services not only to the client but also to the attendant or other family members or any type of caregivers, ultimately the community. And monitoring the patient conditions, very, very important. That is easily because we don't have our fixed timing. Like we can run, you can ask the patient or client to keep in touch anytime as and when he feels like, to more appropriately utilize the staff skills. What are the types of nurse-led clinics and services available? These are some examples of the clinics where fragility clinics, falls clinic, intermediate clinic, and in primary care specific diabetes, most of the clinics are run. Time being, it is most of the clinics are more popular in the clinics where they need long-term services, where they do not go to meet the doctor, where the doctor visit is mandatory only for the follow-up care, or in the treatment aspect also, the patients, we can manage them in the nurse-led clinics. And essential criteria to have a nurse-led clinic, or you have to fill up all this criteria. You have got the setup criteria. These are the boxes which are given. You have to be very clear that you have to have your own admission and entry criteria, whom you can meet, whom you can admission here in this is entry into the clinic, not admitting as inpatient. Entry allowing whom you cannot take up the patient who need emergency care in your clinic where you don't have the staffing facility. Where you do provide services, you may have the 7 days split up in services which are for any minor ailments or for antenatal checkup or for immunization advices or for the follow-up care. When you divide or you split your all 7 days for your caring aspect in your clinic, you have to have your own criteria or policy or some protocols fixed so that you can allow those patients, if they need immediate service from medical fraternity, you should not hesitate, or you may have to have facility to refer them or triage them to such facility. So you have to have links with those facilities and whom you may not see in your clinics, and escalation criteria and referral to other services, pathways, how often to see patient. Because I said all 24 hours you will be seeing the patient, I didn't mean that. What I said is you can have your own time. You can fix up, you can allocate. When you are not available, you can nominate, you can have somebody to help your own friends or the experts to have, or if you have your appointments already fixed, there should not be any gap in between your caring aspect. And these are some evidences where these evidences which I've taken from the patient satisfaction survey, where they felt happy, more comfortable, satisfied in those clinics which are run by the nurses. In heart failure clinic, people receiving nurse-led care experience fewer hospital admissions for any cause and an increase in any cause, a number of participants reaching target dose within the short time period. In diabetic clinic, patients receiving nurse-led care demonstrated better outcomes and costs were reduced because we reduced unnecessary visits where only the reference were repeating the prescription or for some follow-up care or maybe any minor ailments they can avoid, so that avoid visiting the doctors where they have to spend definitely reasonably better fees for the doctors. In monitoring people with the prostatic cancer, nurse acceptable to patients and good outcomes were demonstrated. And with the hypertensive clinic also, Improved outcomes were shown in the studies. The role of the nurse practitioner in nurse-led clinic. Nurse practitioners play a crucial role in the prevention, screening, diagnosis, and management of COVID-19 cases. Given the rapidly evolved nature of COVID-19, practitioners have the professional responsibility to remain current on the most up-to-date evidence for efficiency in treatment. In-person clinic visits and patients avoiding the emergency departments for non-COVID-19 illnesses. There also we have to segregate, we have to see them, and also we have to have a separate provision for them, the clients who are coming with the non-COVID symptoms or non-COVID clients. A few specific examples include providing frequent visits through telemedicine visits for improved blood pressure and cholesterol. We do have to provide care. And here they may not come looking for your only for post complication. I'm not telling, regular checkups also we can do, or we can monitor them to our telemedicines. And for elderly patients also, you can optimize medication therapy and avoid side effects and polypharmacy. Video telemedicine visits also help our functioning. The value of advanced nursing practices overall, you can see holistic, innovative, and evidence-based. Whatever you do, we are doing, we are having support as evidence-based and cost-effective, increased review of medication. Increased review of medication. We do have time allocated, and as I told you, with effective communication and our role functioning, we can do that our services in such a manner that will be more fruitful. And patient and family centered satisfaction is ultimately the result what you can gain through, and more of integrated. Because I said nurse-led clinic doesn't mean I'm the individual. If I am running a clinic, I'm the only one person managing. No, I will have our own team, or it is like, coordinated teamwork. I will have my own set of people whom they can give care in such a way that the patient will be satisfied, or look for the further visit in our own clinic. And advantages of NLC, it contributes to developing nursing and enables us to nurse with because we are functioning with our heart and the head, enriches the lives of those well for our own lives. Very, very important. That is the advantages. And this is, I have given, do we have to be an expert to run a clinic? I have given how we can do from novice to expert scale, because when I start up my clinic, I may start up like, I can just tell people that I'm doing only the particular service. May not be so complicated, may not be like, taking upper hand, like a small way, provided the scope of practice where I am licensed to practice, I can start up like that. Once you start up with a gain knowledge, with your expertising your own work, then slowly you can formulate your own work. You with little bit of gained autonomy, and you can do function in a complex scenario, and you can work, you can improve, and you can give care to the multiple clients. Everything whatever we discuss here is definitely under the scope permitted by the code of ethics, and also our own nursing councils, which permit us to function as independent licensed practitioner. Because as I told you, nurse practitioner means you are not straight away going to your practice. You have to gain your own certified license as practitioner. That is very, very important. How you can improve your own from, like, this is like from novice, the same slide which I showed you. I have just given the curve which goes upwardly, starting from novice here as the beginner, how you become expert. Expert in the sense, in the area you practice, that is what very, very important. From narrow, you're just spreading your wings to become an expert, and ultimate goal is to provide care the people whom you serve. That is the ultimate aim of all of our nurses. The continuum of advanced nurse practice, developing expertise. Each slide what I have given here is from how we can develop. From there, how you become an expert, and how you can cater services in a different setup, in coordinating with the different teams, which we have to include doctors also for any medical opinion. So these are some points I got, like, developing expertise by your practice, becoming a specialist by your constant touch, becoming a nurse practicing at advanced level with your gained experience, your license you obtained, and also the feedback you get from your own clients. And no one is born an expert. But though this statement, to certain extent, I am satisfied. You are destined to be a nurse. That's what I always say, even to my students. Not everyone become a nurse. Even the people who have taken up this courses or the degree program nurses now started deviating from because of the stress they undergo, or they choose the other profession better than the nursing. You have your own innate some genius that you to become a nurse. That's I have a strong belief in that. So with that, you have to just go up in your career. That's what I expect from this. So we have to develop and nurture experienced practice. Nurse clinics can be a safe place for nurses to develop. Yes. So general competencies in NLC, just I've given for your own, just for the students who see this. These are the areas available. The scope is so big. So don't stop with only once you finish, you go and work in an area. So I'm happy, contented, I'm going to stop with this. Don't have a full stop. See the areas, what are all the areas you have, and you to practice as a clinic nurse in a clinic. So practicing autonomously, making decisions on your own, admitting and discharging your own patients, ability to take a clinical history, ability to physically examine. See, when you see the functions here, the competencies from 3, 4, 5, 6, 7, 8, 3 to 8 here, everything you do, you learn. Everything you do in your learning stage, in your learning as a student, you get all this exposure. Only thing, everything you have to put it into practice with proven results. That's what here I insist. What are the special competencies? Look here, competencies specific to services. You can become specialist, nurse pulmonologist. You can be nurse anesthetist. You can do dual roles. You can work as a nurse, you can work as a midwife, isn't it? And if you are permitted, you can do your, because everybody is having interest in doing PhD. Everybody is doing. Yes, do with some sense. You improve your knowledge where you have to put up your effort, where you have to prove, yes, I am competent enough. And the degrees are available. Ultimate thing is, wherever you do, wherever you put yourself, exposing yourself, willing to learn it in depth. That is what I expect from the participants. The treatment goal is ultimately in nurse-led clinic is getting patients' symptoms under control, identifying underlying health problem, slowly improving their ability to function. This is the basic fundamental objectives of the nurse-led clinics. And long COVID, post-COVID syndrome, here, when you see, because why I've taken this treatment aspect from the post-COVID complications, because these are the areas when you see the treatment, almost all the points which have been given can easily be followed up in nurse-led clinics. Apart from moderately or severely affected with COVID, people with mild symptoms and treated in home quarantine can also have the long-term effects, when everyone should continue to take steps to reduce the risk of getting infected. See, when you see the points, these are not easily you can practice, easily you can monitor your own workload of clients. Focusing on breathing exercise that boosts immunity, lowering the stress and anxiety, give relaxation, improve blood oxygen level, and reduce stress levels in the body. Everything is possible through nurse-led clinic. So teaching breathing exercises, and like examples, yoga, pranayamas, and stress and anxiety reduction by counseling and guidance clinics, and relaxation, how they can divert their mind, slowing down the anxiety level, improving or giving some solution to be relieved of the stress, improving blood oxygen level, and what are the foods they can take, and how they can modify, what are the exercise they have to practice. These are not easily practiced in the nurse-led clinics. And improving healthy sleeping habits, through modification in behavior, avoiding a mobile or TV. Every day we are getting information. What we are going to then is we can teach them in our own setting. And balanced diet and light meals, because the next speaker who is going to talk about, Mrs. Viji, is going to talk about this most relevant to this topic, almost close to the topic, is actual versus optimum health habits. That is also very easy to follow. We are not going to take up anybody's, we are not to grab other opportunity. Whatever you do, you are going to put your full-fledged, your concentration and focus, improving the health standard of the human community. So screening and diagnosis, this is possible. Nurse practitioners serve as the first contact in the COVID-19 screening and triage tests. They play a key role in determining whether the patient can be treated and discharged on the spot or directed to the appropriate care setting in the hospital or other alternate site. The clinical presentation is quite variable, ranging from asymptomatic to severe illness and death, making screens algorithms imprecise. So the nurses who are working in this triaging area or in the casualty, or maybe in the area where they are receiving the first time people who are working also, they are the people who are deciding what are all the screening areas the patient have to be checked. So you are privileged, you are working in that area. So less commonly reported symptoms include headache, rhinorrhea, sore throat, vomiting and or diarrhea. Screening protocols for COVID-19 should query for them cardinal signs of new onset of fever and respiratory tract symptoms. First of all, when you look after these patients, when you suspect, first you have to protect yourself. That's what I'm stressing every now and then. I'm stressing. Protect your health and safety in the first line. Then you can take care of. If you are healthy only, you can cater the entire population. Very, very important. You first protect yourself by repeated saying, like always follow the rules. Rules are always, for a joke, we'll say all rules are always meant to be breaking. No. Here, when it comes to pandemic situation, definitely you have to keep up the rules, follow the rules. Then only you have to, you can show, you can just advise your own clients. Lab testings also should be performed in the suspected cases, and how we can do, like the coming slides I will be showing. And taking nasopharyngeal swab, oropharyngeal swab, nasopharyngeal wash, aspirate. If patient is suspected of having COVID-19 positive, the nurse practitioners should immediately implement isolation and recommending infection preventive practices. Impact of senior nursing leadership during COVID. Planning and redeployment of efforts led by senior leaders were imperative to ensure crucial staffing needs were achieved. Multi-speciality nursing team composed of nurse practitioners, nurse educators, clinical nurse specialists, frontline workers, and nurse scientists worked together synergistically to have beautiful team to educate staff and their patients, streamlining performances and implement clinical trials across the medical center. Here, why I mention this is because the clinic is not exclusively, I'm talking about, even in the work area, wherever you work, the role of senior nursing personnel, whom they can train, whom they can educate, how you can coordinate between the groups, inter and intra, so that the ultimate target is achieved. The role of the nurse practitioner in NLC, crucial role in the preventing, screening, diagnosis and management of COVID-19, given the rapidly evolving nature of COVID, have the professional responsibility to remain current on the main up-to-date evidence for efficacious treatment. In-person clinic visits and patient avoiding emergency, this, I think I've already given you this, the roles. And not only with the pandemic situation, even if the people from the reproductive age group, postpartum health program, management of complications associated with postpartum hypertension, preeclampsia via video telemedicine is convenient. New mothers who prefer not to pack up a newborn and travel higher risk areas to discuss titrating down our medication may be experiencing symptoms such as headache or visit changes that would result in an emergency department also be treated or may be counseled through our NLC. Another advantage is reduced institutional overload while having the ability to bill for professional fees. So I'll skip up. So COVID education for women and children services have already given you, and some more these areas where you can incorporate your services. What are the precautions to take post-COVID recovery? People with comorbidities like diabetes, hypertension, cardiovascular diseases, kidney diseases, liver diseases, not left any system. Every human being and all the systems are involved. Immediately go back to the ongoing pre-COVID medications, get vaccinated after 45 days of post-recovery. This is in general information. I'm just I'm giving you as information. And diabetes, I've given a special note here because the so-called the fungal infection mycosis, which is affecting the eyes. When you see the some research report or the evidences, and the people who are higher percentage with the diabetic problems. How to treat coronavirus at home quarantine is general information. I'm just giving you for us to just have an idea. I think all of us will maintain this. We have to maintain, we have to insist in maintaining also. And if they need to go to the doctor, the person should wear a cloth face covering. Very, very important, maintaining distance and use sanitizer appropriately. So before, nurse-led clinic, why we have to kick? The objective was, what do we want to achieve in having such clinics? Reduce overall risk in the community and improve health outcomes by decreasing the complications, morbidity and mortality, improving the quality of life. Use a comprehensive, well-coordinated, systematic approach to healthcare achieve the goals. And build capacity, collaboration in our health team, adequately compensated for best health practices and improve outcomes. So these are some models I've just got. What are the objectives? If anybody is interested after they are got experience, professional experience, or who want to start a clinic on their own, have this as some information. Where do we begin? I have to set up my own system. First, I have to identify my own target group. Like example, the various clinics evidence we got, like cardiovascular disease or diabetes or asthma, and decide on the type of tool you will use for your own assessment, and you have your own tool prepared. And you have to go for database. Search for database, age group, can be used for specific group, and search should bring up prioritized list of patients, can be used to mail, merge for the follow-up care. You can have your own database. So this is an example I've given. This is the way you can follow them through. And in the pre-clinic setup or the clinical day, what the work, nature of work you can follow, and post-clinic, what you have to do. And I've mentioned here this, including a general practitioner, the doctor, for any medical help you need. And the equipment, as basics, you have to have some equipment in your own clinic, and the paperwork, what you are supposed to do. That's what a checklist, final appointment list, patients file, everything, you have to have it in your own filed up electronically, or you have to have your hard copy also. At times where you may be you cannot believe on this electronic support. GP role in nurse-led clinic here is what the doctor can help, So there you have to include him in your multidisciplinary team. Why do we bother? Why we are bothering about so much about our own profession and to run up the clinic? A focused practice, to have a focused practice, empowering our own staff by predictability of the clinical enhancement ability to deliver improved medical outcomes, and increasing our competitiveness, very, very important. Greater involvement of practice staff in clinical outcome, patient appreciation and retention, very, very important, because after all, we are serving the human population. And before I could summarize, this is what I'd like to say. During an unpredicted time, nurses have risen to forefront across the world. We are in the front line with the unfamiliar practice of environment like pandemic. Where we can improve our services by starting from the screening up to treatment, to ensure nurse remain updated on updated in the patient care, and implications for nursing education as a result as educator, where you have to improve. And because COVID pandemic will be felt for years to come. Yes, that's what people say. At present, people are telling this is there up to 2023. We don't know. We are still at the, we hope that we are at the end of second wave, but we are ready for already for the third wave. So nurses specialists generates new knowledge. That's what we expect. The message is consistent. Nurses are leading the way in 2021 to a better, healthier tomorrow. And capitalize on the clinical expertise of the nurse too. I want this area for all the takers. Please remember that you do can practice, you do have your own clinic. So that's what I would like to say at the end of my session. And thank you once again for all these organizers and the experts whom the earlier speakers who have shared their knowledges. Really, I'm so happy to be one among the captains of the big ship of Narayana. I thank Madam Indira for giving this wonderful opportunity. Thank you very much.
Thank you very much, ma'am, for your in-detail explanation. Thank you once again.
Any queries? Maybe if time permits, I can answer, or maybe later on we can have it. I think I've concluded.
Analysts can post any questions if you have in the chat box.
Can I stop sharing this, Usha?
Yes, ma'am. Yes, ma'am. We didn't get any questions right now, ma'am.
Okay, it takes some time, because this is first of its kind. We are just planning. I think now itself the participants have started planning how to have our own thing. Hopefully, yes, with that idea. Okay.
Thank you, and we'll break for our lunch now, and webinar will be continued by 2 o'clock.
Thank you, Usha. Thank you.
Thank you. Thank you to all the participants. We'll see you.